We are on live.
Okay, great.
20 people have joined here. How many online?
Madam, they are logging in. It is on YouTube live, so many more have logged in.
Yeah, that's right.
Yeah.
Okay.
Yes, Supriya, please start.
Yeah. So a very good evening to all respected faculties and all the delegates who have joined today. This is the 6th episode of Seed to Bloom series that has been organized by Fertility Enhancement Committee of ISOPAB, and that is in collaboration with Lucknow, Gorakhpur, Patna, Ranchi, Bindia, Dibrugarh, that is from Assam, Bengaluru, and Karnataka, Hyderabad city chapters of ISOPABs. So we have faculties from all the places. So without wasting time, we'll just start the webinar. And just to introduce Madam Dr. Lakshmi Shrikhande, Madam, who is the convener. She is the chairperson of this committee, Fertility Enhancement Committee of ISOPAB, and she is the convener of this program, Seed to Bloom. Madam is the immediate past chairperson, ICOG, Indian College of OBGY, National Corresponding Editor, Journal of OBGY India, Jogit, National Corresponding Secretary of Association of Medical Women India, President ISOPAB Vidabra Chapter, Chairperson IMS Education Committee, Chairperson Fertility Enhancement Committee of ISOPAB. She is member of SAFOG Education Committee, President Association of Medical Women, Nagpur, Senior Vice President FOXY 2012. She was also the President of Menopause Society in the Nagpur 2016-18, President Nagpur OBGY Society in 2005-6. Madam is a recipient of so many of awards as Nagpur Ratan Award by the Union Minister Shri Nitin Ji, then received Bharat Excellence Award for Women's Health, received Mehru Dara Hansotia Best Committee Award for her work as Chairperson HIV AIDS Committee FOXY in 2007-9. That is a very prestigious award. She also received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child. She had been delivered 22 orations and 450 guest lectures and publications, more than 42 in national and 21 international journals. She has also sensitized 2 lakh boys and girls on adolescent health issues. At present, she is the medical director of Shrikhande Fertility Clinic, Nagpur, Maharashtra.
I'm
And
busy.
she has done great work as ICOG chair, and everybody knows that. So over to you, madam.
Thank you. Thank you so much, Supriya. May I have the slide of Dr. Supriya? Because before starting with the webinar, I would definitely like to introduce very sincere, hardworking, dedicated co-convener of this Seed to Bloom series, Dr. Supriya Jaiswal. She is Vice President, Patna OBGY Society. Currently, she is Chairperson of Adolescent Health Committee of FOXY. She is Joint Secretary, Sauci, Bihar and Jharkhand Chapter, Chief Consultant as SM Hospital, Patna, and you can see she is holding so many posts in so many organizations, and she has been awarded with Dr. MP John and Dr. GV Ellen Murthy Award for Best Short Paper in Obstetrics. And apart from these, many awards have been bestowed on her for her academic performance. She was organizing secretary of Boxcon 2022, and she has special interest in high-risk pregnancy and preventive oncology. So Supriya, thank you so much for all the coordination and hard work you have put in. And now I take this opportunity to welcome all the esteemed experts, faculties, our National President, Dr. Arup Kumar Majhi, our National Secretary General, Dr. Pragya Mishra, Chief Guest, Dr. Vandana Vadvekar, Guest of Honor, Dr. Parul Kotadawala, along with all the speakers, moderator, and panelists. So before we start, let us have a prayer song and Ganesh Vandana. Saiti, please play that video. Yeah.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय तनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
I request all the faculties and dignitaries to join virtually to light the summit. Yes. So after having blessings from God, now it's time to have blessings from our seniors. And I take this opportunity to welcome all the delegates who have logged in on this platform as well as on our YouTube Live. First and foremost, I must thank Dr. Arup Kumar Maji for giving me free hand as far as organization of the Seek to Bloom series under the Fertility Enhancement Committee of ISOPAB. He is a very humble, kind-hearted gentleman, and to introduce him formally, he is Professor Santiniketan Medical College at West Bengal. You can see he is author of so many textbooks, former professor and head of RG Kar Medical College, Kolkata. He was President Bengal ABGY Society, President of Kolkata chapter of ISOPAB, and he was Scientific Committee Co-Chairperson for AICOG 2023 Kolkata. He has got 30 years of teaching experience. He has been undergraduate, postgraduate, and DNB examiner for various universities. Sir has got more than 100 publications in national and international journals, and he was also the editor of our ISOPAB journal and past national corresponding editor of Jogi. So with this introduction, sir, we are requesting for your pearls of wisdom for this episode 6. Maji, sir.
Good afternoon, everybody. Good afternoon, everybody. So I am taking my video and am I audible?
Sir, your voice is breaking.
Actually, the net connection is very poor here. That
Yeah, I
is
understand.
trouble. So, all of you, good afternoon, everybody. And the people of the City Globe series and by participation of
I think he has been logged. He's
I
logged.
I believe we can
Yeah.
continue and he
Yeah.
can join whenever he can.
Yeah. Thank you, Dr. Parul. Please display the slide of Dr. Pragya Mishra. Pragya is just a phone call away for any assistance, any guidance. Thank you, Pragya, for your wholehearted support towards the Seek to Bloom series. She is consultant infertility specialist at New Life Test Tube Baby Center, and she is Secretary General of ISOPAB. She was chairperson of Genetic and Fetal Medicine Committee of FOXY. She is founder secretary of Bihar chapter of ISAR. She was vice president of Patna OBGY Society, and you can see that she has hold many positions in various organizations. She is examiner for MRCOG examinations, and she also imparts FOXY certified colposcopy training. List of awards you all can read and see. She is a great academician, orator, and a very humble person and a great friend. So I invite Dr. Pragya for your pearls of wisdom for this episode 6 of Seek to Bloom series.
So, good evening to all of you. It's quite thrilling, to see that Seed to Bloom series is just blooming, and it's the sixth episode, which it was started by Dr. Lakshmi Srikhande, who's the chairperson of Fertility Enhancement Committee of ISOPAB. And at every 2 monthly intervals, she's making it. She's making a lot of efforts to just carry on with this, persistently and sincerely. So every 2 months, we are getting the opportunity to have one international faculty and two national faculty. And today, so many panelists are also there. And it's quite nice that, she has involved chairpersons and secretaries of a lot of chapters like Lucknow and Gorakhpur, Patna, Ranchi, and I think, and also the newly formed Kalaburgi chapter, whose chairperson is Megha Kamla Purikar, and it was formed, in fact, in my secretary generalship. So I just congratulate you, Dr. Lakshmi Srikhande, for this. And well, I can see the chief guest of today's program, Dr. Vandana Valvekar, guest of honor, Dr. Parul Kotdawala, who's also taken over as the ICOG chair. And of course, I can see my friends, Dr. Madhumati, Dr. Supriya Jaiswal, Dr. Jyotika Desai, and so many others who've locked in. So it's very nice, I think you're going to give us a scientific bonanza today to all the delegates of ISOPAB. So wish you all the best for this program. And I really loved the cases which you have selected for the panel was on scar endometriosis, and the other one is what is it on?
IVF pregnancy.
Oh yes, of course. It's something very close to you, to your heart, and to my heart as well. So thank you so much. And
Thank you,
thank you for the kind introduction as well, and also Dr. Supriya for persistently logging in on time for this program.
Thank you, dear Pragya.
Please
Yeah,
continue.
President Dr. Maji, of course. How can I miss him?
You got the esteemed faculties and very senior person, Madam Vandana and Dr. Parul Kotdawala, and there are Bangalore, Lucknow, Patna, Ranchi, Indore, Dibrugarh, and Gajapuri, and Hyderabad all are. You have really, both of you, the convener Lakshmi and Supriya, have done a lot job at ISOPAB. So continue wishing a grand success of these episodes.
Again, we lost him. Thank you, sir. Thank you so much.
Thank you.
Please display slide of our chief guest, Dr. Vandana Valvekar. And I must say that being a chief guest, she logged in at sharp 4. Madam, I appreciate your punctuality and your humbleness. And I welcome you as chief guest on this platform of our Seed to Bloom series. And as you can see, Madam was the former dean of Wadia Maternity Hospital. She is Professor Emeritus of Wadia Hospital and St. GS Medical College. Madam is former President of Mumbai OBGY Society, Indian Federation of Ultrasound and Medical Biology, then of ISOPAB, and she is past President of Association of Medical Women of India. Madam is past Vice President of FOXI, former Secretary General of MOX. Madam is member Ethical Committee of Wadia and Bhatia Hospital. She is a member of Labor Welfare Board of Maharashtra, and she is initiated the very first ultrasound training program for gynecologists and Wadia Hospital. Madam, I know you. You are a great academician and the teacher's teacher. And it's an honor and privilege for us to welcome you here as a chief guest. So we invite you for your pearls of wisdom and blessings.
Thank you, Lakshmi. It's a pleasure. It's a pleasure and a privilege to be here. Dr. Arup Kumar, Dr. Pragya, ISOPAB has taken such a large number of organizations and states which are participating ever since I joined, when it was a mere in the infancy, when Dr. A.C. Mehta was one of the founder members. So since then, I'm glad the whole thing has taken off so well. And I'm very, very thankful to Lakshmi and Supriya for inviting me today. It's a privilege. What I thought was that the two episodes, the two subjects that we have selected are the recent trends in the practice for the last 10 years. Like we see a lot of women with 2 or more cesarean sections nowadays than we used to see before. Number one. Number two is that with the women's emancipation, what's the word, but the women's careers and the family situation, plus the modern society ideas, we are needing ART much more often than what you used to need before. And ART brings about all issues or problems and this thing. I'm glad that's one of the issues. And I'm sure these are the situations which are going to help today's delegates to efficiently do their practice much more efficiently to the satisfaction of the patient. So I wish the 6th episode called the Bloom, Seed to Bloom, it's already blooming if you ask me, Seed to Bloom, success, and many others to success for Z. Thank you, Lakshmi, and thank you, Supriya, for all that. My respects to Dr. Arup Kumar, President.
Thank you, madam. Thank you so much. Now I welcome our guest of honor, Dr. Parul Kotadawala. I always ask him, you are so cool and so humble. And he has recently taken over as chairperson of Indian College of Obstetrics and Gynecologist. He is a great endoscopic surgeon from Ahmedabad, professor and unit head at Sai Institute of Medical Sciences. He is also running his Kotadawala Women's Clinic. He is senior consultant at Zydus Hospital, Ahmedabad. He was vice president of ISOPAP, chairperson. Currently, he is chairperson of Education Committee of SAFFOG. And you can see that he is India coordinator for New European Surgical Academy. He is India coordinator for International Adhesion Society. He was Vice President FOXY way back in 2006. He was President of SOGOC, President of Ahmedabad OBGY Society, and he was Chairperson of Scientific Committee of AICOG 2017. Above all, I know he is very, very passionate for the teaching and for endoscopy work. So Dr. Parul, it's our honor and privilege to invite you here as guest of honor for your pearls of wisdom.
You're getting a pearl necklace today.
Please unmute here.
Thank you very much, Dr. Lakshmi. Very live wire lady, and I have just taken over from her the ICOG reins. Madam Vanna Valvekar, such a dynamic lady, you can't talk about her as very humble. Okay.
Okay, Parul.
No, but I accept. I mean, you are one of the most dynamic lady I have observed in our fraternity.
Thank you very much, Parul. I appreciate.
I salute Dr. Arup Kumar and Dr. Pragya, ICOG office, and of course Lakshmi and Supriya for asking me to be part of this very interesting webinar. The topics are, of course, very interesting. Cesarean section, scar, and essentially the isthmosil is something very new on the block. Only 10 years back, we started learning about this particular problem. Otherwise, we never took it into account much. ART pregnancies are always an issue, especially in India, because I believe that unless you perform cesarean in time, they never end up in vaginal delivery, unless you miss out doing a cesarean. So I observe that Indian situation is different. So let us hope we will have some discussion on that.
Yes.
And of course, scar endometriosis and old age pregnancy IVF are also both very pertinent issues for us to debate about, because there are very different opinions on them. So I wish this program all success. For ISOPAV, I can say my association goes back to, I still remember 1999, the ISOPAV annual conference was in Bangalore, where me and Amar Bide went over and participated. 2006, we conducted All India ISOPAV conference in Ahmedabad. And due to some unforeseen circumstances, last year we could not do it. Maybe in near future we will be able to do it. Thank you very much. please carry on with the webinar.
Thank you. Thank you so much, Dr. Parul, for joining. And now I hand over to Supriya for starting off our scientific session. Supriya?
Okay, thank you, madam. And thank you everyone who logged in. So thank you very much. So we begin with the first scientific session. The topic for this session is cesarean scar diagnosis, assessment, and impact on menstrual and fertility function. To chair the session, we have Dr. Jyotika Desai. She is senior consultant in Dr. P.R. Desai Hospital, Bangalore, DNB teaching faculty at that same place. She's been the chairperson of IMS Education Committee and honorary secretary ISOPA Bangalore chapter. Chairperson website committee IMS, past president of Bangalore Society, past president of Bangalore Menopause Society. Throughout, she had been in the administrative post. Madam is the recipient of Best Committee Award for IMS website chairperson. Lifetime achievement bestowed on her from the Bangalore Society of OBGYN. And she has also been awarded as Unsung Hero Award 2019 from IIRRH in Life 2019. So welcome you, Madam, Dr. Jyotika Desai. And the next chairperson is Dr. Neelam. She is the medical director and consultant, Santati Fertility Clinic and ART Center, Arvind Hospital, Patna. She is also the consultant of Sadbhavna Clinic, Bihta, Patna, Vice President, Patna Menopause Society, Joint Secretary, Indian Fertility Society, Bihar Chapter, President, Patna OBGY Society in the year 1920, Vice President, Patna PARB, 2022 to 23, Chairperson, Cultural Committee, LabourCon 23, and co-author of Critical Care in Obstetrics. Madam has also contributed chapters in patient awareness books. Her special interest is in high-risk pregnancy, safe motherhood, population stabilization, and traveling. So I welcome you, Dr. Neelam. So over to both the chairpersons. May I request Dr. Neelam to kindly introduce Dr. Kamal Ojha, sir.
Thank you, Supriya. Thank you so much for a kind introduction, and good afternoon to all of you, all Dr. Manji and all the our dignitaries who have joined. And so to introduce Dr. Kamal Ojha is really an honor. He is consultant gynecologist and honorary senior lecturer at St. George Hospital, UK. He is also medical director of Concept Fertility and member of Royal College. He has since 1995. Special interests are in fertility treatment, oocyte donation, and advanced ultrasound. He has published extensively in national and international journals, as well as authoring chapters in textbooks. He was founder member of the International Society for the Fallopian Tube and Reproductive Surgery, and he is an active member of the European Society for Human Fertility and Reproduction, that is ESHRE, the International Society of Ultrasound in Obstetrics and Gynecology, ISOG, and the British Fertility Society. So we are fortunate to hear him, and the stage is all yours, Dr. Ojha. Please.
Yes. Dr. Neelam, he has sent his recorded lecture, so we will be playing his lecture and he will be joining us live for question and answer session. So technical team, please start his video, and I request all the delegates to please listen carefully, post your questions in the chat box. He will be with us to answer all the questions which you have in mind, because topic is very, very different. I was so impressed with this talk. This was delivered by him during the Femtech conference. We always talk of cesarean scar diagnosis, but what he focused was on the assessment and impact of the cesarean scar on menstruation and fertility function. So it is something new and unique talk. So let's hear him, what he has to say on this. Please start his talk. Yeah.
Good afternoon, everybody. It's nice to see you also through a webinar. My name is Kamal Ojha, and I'm speaking on cesarean scar defects. I'll just upload my slides. I'm a consultant at St. George's University Hospital in London, and I would like to thank the IFS for inviting me to give this lecture. Some of you may have listened to this lecture in the past, but I think it's such an important thing that we should be focusing on this. So the lecture is really looking at two aspects here. looking at caesarean scar defects, but also looking at how a new clinical scenario should be investigated and defined and treated, and avoiding unnecessary treatment, but providing the best care. So if you go back, say, 20 or 30 years, caesarean scar pregnancy was not known. It was not so well known, and people didn't know that it existed. But if you talk to patients now or to clinicians, they will be well aware of this condition because of the problem it focuses and faces. The rate of caesarean section, the rising rate, is the primary reason why we are in this situation. So let's go back to the basics. We all do IVF. We put an embryo in the uterus, and then they could implant an A, B, C, D, E in the fundus, anterior posterior wall in the upper middle third, and the lower middle third of the uterine cavity. But occasionally, these pregnancies could go into the wrong positions, like an ectopic pregnancy or a caesarean scar ectopic. And that's where the whole talk is about. So, well, for understanding this, you need to have a good scanning technique, 2D and a 3D ultrasound if you have, and a saline infusion sonography. So if you look at scanning, I always like to say these few very basic things to all my colleagues, junior colleagues especially, because they're the ones who are the future, that if you're scanning, when you're putting the probe, look on the screen, identify the landmarks before the probe goes into the vagina, because you put the probe in the introitus and just wait for a few seconds. You can see the urethra, you can see the bladder, you can see the rectum in the back and the vaginal path. Maintain good contact throughout the examination to get a good image. Follow the cervix, anteverted or retroverted. Very slow movements to see the uterus in longitudinal and then transverse position. And lose the structure you're scanning so you can make sure you don't miss a uterine malformation. What about the Delphi study? This is what I wanted to emphasize today, that caesarean scar defects is a new entity. And to define this entity and to clearly get the symptoms and signs and management, the Delphi study was proposed. So it's a consensus based on a modified electronic Delphi record. It is a predefined rate of agreement. That means that 70% of the group of people in the study should agree to what is being said. The experts who participated in the study, they were picked from people who are published in this area, or they're participating in expert groups. An online received questionnaire was sent between 2021 and 2022, and as published in the JAMA. And total of 31 of the 60 invited experts participated. Majority worked in university, specialized in benign gynecology, and worked in Europe. So you can see the group of people who are responding here. And these rounds were required to achieve consensus. 3 rounds were required. So I mean, the same points were sent back to these, and hence the study has come back saying symptomatic niche and its differentiation from a sonographic finding only is important. Experts agreed to name this condition caesarean scar disorder, CSDI, and is defined as a uterine niche in combination with at least 1 primary or 2 secondary symptoms. And the primary symptoms are post-menstrual spotting, pain during uterine bleeding, technical issues with catheter insertion during embryo transfer, and secondary unexplained infertility combined with intrauterine fluid on a scan. Whereas the secondary symptoms are dyspareunia, abdominal vaginal discharge, chronic pelvic pain, avoiding sexual intercourse, odor associated with the abnormal blood loss, and secondary unexplained infertility, secondary despite having ART treatment. So once we've defined it, so we got the secondary symptoms, which you just said, can lead on to secondary infertility. It can lead to a negative self-image and discomfort during participation in leisure activities. And of course, odor with the abnormal blood loss. So that's such an important factor. So to sum up, the Delphi study was designed to come to a consensus between experts The disorder was called Caesarean scar disorder. And symptomatic niche is the one that we should be looking for, not the sonographic findings only. And using a standardized definition, it makes us recognize the condition better, improves patient care, prevents over-treatment, which is very important when a new thing comes up, and create a patient-centric foundation. That means the patient decides what is important and what is affecting her, and the niche-related research in the future. So it is so important to get these things under control. So let's go back to the diagnosis. It's a 2D ultrasound, saline infusion sonography, and 3D ultrasound for those who have it. So 3D is not essential, but it's useful if you've got it. Here you can see a longitudinal view with a triple layer endometrium and a cervical canal clearly. There's no scar defect here. And you can see another patient, which is in the follicular phase and has a Caesarean scar defect with fluid inside the cavity. And that thickness is useful to be known. Here it is 4.9 millimeters. So I think anything above 4 millimeters is useful. And saline infusion sonography, for all those who don't know, is putting a catheter in the cervical canal. In this case, it is in the cavity. Sometimes it slips out from the cervical canal, so we put them in the cavity. But ideally, this catheter should be in the cervical canal, and that allows you to insert saline and see the expansion of the cavity and scar defect. Here you see, typically, the catheter is in the cervical canal, and the cavity is distended. On a 3D scan, there's a longitudinal view and transverse and a 3D view. So you can see fluid clearly distending the cavity, and the cavity is normal. If you go on to somebody who's got a Caesarean scar and you put the catheter low down, cervical canal expands, and then the fluid goes into the scar. And you can see the top half of the cavity is normal, and anteriorly there's a defect. And this is with 2D saline infusion sonography, and it's a dynamic test. Here, again, you can see in the same patient a Caesarean scar on putting saline. And if you have a patient who had a myomectomy and you're concerned about defects there, you can do the same thing. So here's a lady who's come post-myomectomy, open, and we've got a catheter, we insert saline, and we can see the defect in the cavity. And that was important to assess, so we could treat that and then decide further treatment. So what are the scenarios through which you see these patients? Let's look at gynecological. They're postmenstrual bleeding, there's dyspareunia, painful periods. Mainly that's the group that comes to us. In my gynecology clinic, I'm getting patients who are having dyspareunia and painful periods, as well as postmenstrual bleeding. The woman who come to my early pregnancy unit is early pregnancy Caesarean scar, and of course, placenta previa with invasion into the scar. That is a late pregnancy. And if you look at infertility, it's unexplained infertility with Caesarean scar defect, with fluid in the cavity, or secondary unexplained infertility, where despite doing ART, they have not conceived. So you could have two different groups turning up in your infertility clinic. So let's go to this image. This image shows us in a patient who's had a Caesarean scar, the embryo implants, and the pregnancy is well in the upper half of the cavity and anteriorly implanted, and that is absolutely fine. You have another patient in the B, where the pregnancy is just coming to the upper level of the niche. So more or less you can say this is normal, but there's a possible placenta maybe invading into the niche. And then you got the third scenario, where the pregnancy is sitting on the niche. It's not in the muscle, not in the cavity, but sitting. So it's invading into the Caesarean scar. And the last one is fully inside the Caesarean scar. In fact, the pregnancy is coming out in the serosa of the uterus in the lower uterine segment. So you can see how you can put them into 4 categories of Caesarean scar or pregnancies in the uterus, and therefore, when you're comparing it research-wise, it'll be very useful. Here you can see how the scan probe is kept there. You have the bladder in front, and you have the niche, the defect, and then the cavity up there and cervical canal below. So if you draw a line, you will see that there is above the niche, there's the normal muscular thickness, and then you got the reduced muscle thickness with the niche. And so the pregnancy that is on this half of the niche is normal, whereas those which are in the niche or beyond this line is more likely to be a cesarean scar pregnancy. So you can see this is the line we have drawn. The niche is on this side, and that's the endometrium. So it's important to just sort of get these landmarks clear, at least mentally, so it helps you. So you could have a pregnancy that is just completely in the cavity, and there's a gap between the cavity and the upper part of the cavity and the muscle, which is just below it, and then the niche starts. So that is the ideal scenario to say this is not a cesarean scar pregnancy. So here you have three scenarios. You have pregnancy sitting on the niche, and part of the placenta and the pregnancy is going into the niche. So you look at the blue line that separates it. Most of the pregnancy is on the right side. And then you have pregnancy in the beyond the line, which is the cutoff line, but not coming out on the other end. So it's in the between the two muscular layers in the niche. And in this scenario, you can see the pregnancy has gone beyond outside, pushing into the serosa, away from the midline echo, and part of them is on the outer. So there's an outer line and there's an inner line. And in this case, it's gone beyond the outer line. So it's interesting scenarios, as you can see in the scan pictures. Pregnancy is on this side, pregnancy is beyond this one, and then this one is beyond the outer line, which is this one. So that makes the whole story change, because the more it's outside, more likely to affect the bladder, bleeding, and all the aspects. Here you see a patient, which we saw a while back. The pregnancy is in the muscle. It's the variety where you've got the cavity separate. This is the cavity and the cervical canal, and the pregnancy is in the scar. So we had seen a series of 18 ectopics, and this is Davor Jurkovic from University College of London. He published in 2003, and he treated them successfully with local methotrexate and plus minus potassium chloride. The potassium chloride was given when there was fetal heart and to reduce the heartbeat, and then give the methotrexate. Again, while you're dealing with cesarean scar pregnancies, it's important to diagnose them early, check that the cavity is empty, pregnancy is low down, in the cesarean scar defect, define where in the scar is the pregnancy located, as I explained earlier, counsel the patient of the potential risk, and intervene early. So cesarean scar pregnancy, the treatment is early intervention, evacuating the pregnancy under ultrasound guidance, avoid using the suction cannula at the scar. So technically, the tip I give my colleagues or the registrars is that you see with the scan where the location is. Once you're happy it is, scan the patient transabdominally, put the cannula in. The cannula is pacing posteriorly, and then go in the cavity and turn around, and then start the suction machine. So you're avoiding the suction at the cesarean scar. Observe for bleeding after you finish by ultrasound. You can massage the uterus by manual massage, or if the bleeding is not settling, then put a Foley's catheter, 5 French or 5.5, into the scar and then inflate the balloon. Leave the catheter overnight, and generally the routine measures will stop, but sometimes you need the Foley's catheter, and that it takes care of the bleeding. Obviously, if it's not taken care, then we have to go laparoscopic view and put sutures in the scar. So if you see a patient and it's a complex case where it's going more on the outside line, then you should seek expert help. And so if there's an AV malformation or there's vascularity and the gestation is much higher, in those cases, I think it is important to refer them to a regional center. A regional center is somebody who's done a lot of cases and has the expertise and facilities to take care of a bleeding patient, as well as doing hysteroscopy and laparoscopy. So suture may be required, and rare situations with uncontrolled bleeding, you may need a hysterectomy. So I think it is important that you identify the ones who might have problems and treat them in places where you've got expertise around. So with infertility, presence of fluid is a dilemma. What do you do? So in situations like that, if the fluid is persisting and you've got embryos there and you don't want to put them back because of the fluids, if you do a hysteroscopy and resect the lower lip of the niche, then the fluid will drain out and therefore will not collect. Having said that, if pregnancy does occur, it's likely the pregnancy may go in the scar because we're removing the lower lip of the niche, you're increasing the space between the two layers of the niche and therefore the space for the embryo to implant. So probably a repair of the niche may be a better outcome. And the repair should be done laparoscopic with a combination of hysteroscopy, and that might be the way forward. So let's conclude. The process of defining terminology in an emerging clinical scenario is typical. Example is this CSDI. The process is called Delphi. So research to improve clinical management will be there. Diagnosis will be held with 2D and saline infusion sonography. It's a dynamic test. So when you put the saline, you can see the scar defect expanding. Treatment for CSDI was only not for coincidental ultrasound findings, but for symptomatic. And early consider early diagnosis and intervention where there is a pregnancy to seek expert help. So in conclusion also, I think this story about the Caesarean scar defect disorder is evolving, and we should keep an open mind and look out for it. I would say on behalf of the British Fertility Society Journal, if you're interested in publishing articles about this or anything else, please do contact us. The Indian Fertility Society Journal has a research development group and encourages young as well as clinicians who are experienced to publish their data. For those who may be interested to get in touch with the friendly team for the human fertility, you can go to the website. And for our IFS organization, there is a group, a very friendly team who will be happy to help you. I'll be happy to take questions. I know this is a recorded lecture, but I'm available to answer questions. Thank you once again for listening and inviting me to give the talk.
Please unmute yourself. So now he is here. If you are having any questions, please post in the chat box so that he can answer all your queries. Dr. Ojha, in the meantime, you can also just reiterate your points about the talk.
Yeah. Good afternoon, everybody. Apologies for not being able to say it live because I've had some research commitments, and I'm just coming from the lab and from the theater. So I would say Caesarean scar defect is now becoming more and more common in our practice. So I do a Friday afternoon theater in my hospital, and they tend to keep it for me because I'm doing most of the cases. So my registrars also come and help me and train. I see about, say, we do a lot of early pregnancy. We're a regional center, so we do 3 or 4 cases a month. So the numbers are huge. Of course, linked to cesarean section, but most of them are just at the niche, and they're managed by ultrasound guided suction evacuation. Rarely we get patients which are complex, but that's why the definition, defining what type it is and allocating them to the right center is appropriate. So it's such an important thing. And counseling the patient if she wants to continue the pregnancy is another thing, because the risk of hysterectomy and placenta percreta increta. And then the fetal medicine unit gets involved. They do intensive scanning to see where the placenta has gone in. So that is the key point, I would say. Assessment, early assessment, diagnosis, and management. Please do ask me any questions.
Yeah,
I'll be happy to answer.
A couple of questions, Dr. Kamal. How do we deal with dysmenorrhea and menorrhagia and CSDI?
Yeah, so it depends again. When I see patients in my one-stop gynae clinic, the patients come and then I see the scar defect and I see some blood in the cavity, in the scar and thing, I explain to them. Many of them are reassured and they don't want to do anything. So the other thing is, if you stop the bleeding by giving contraceptive medication, then again that will stop. So those are two things we use depending on what they want to do. If it is something that they want to get cured, then we do hysteroscopy and removing the bottom lip of the niche, and that way it drains out. Obviously, as I said earlier, it's a dilemma if they're trying to get pregnant because that opens up the gap and cesarean scar pregnancy is higher.
Is there any cutoff for RMP to take decision regarding operative interventions for CSDI?
So there's no cutoff. Basically, the earlier we do, the better.
Okay. Is there a possibility that the pregnancy may grow towards uterine cavity normally?
As I said, if you can define it with those criteria I showed, the images I showed, the one that are lying just above the lip, they will be always okay. The one that's sitting on the niche, they might have placenta percreta increta, but the pregnancy will remain in the sac. Once they're between the two layers, the third variety, that one will not. Serosa one, that's a bad news.
Injection methotrexate should be given in IV or into the sac, which is the better. And
We don't use methotrexate a lot. This was published before. Now we are going straight for suction evacuation. So we don't use methotrexate because those who are trying to get pregnant, they have to stop pregnancy for 3 months because of the effect of methotrexate. So the use of methotrexate is going down in general in ectopic pregnancies in tubal also. We don't use methotrexate nowadays. We do conservative treatment, follow them up, and in those patients where they're persisting or rising, we go and do laparoscopic salpingectomy or salpingostomy. So methotrexate is losing its importance in our clinical practice.
And what are the measures we should take during cesarean to avoid formation of niche or CSDI?
Yeah, so there is a suggestion that when you're repairing it, do it in 2 layers, in the sense, get the layer which is in the cavity approximated properly. Okay, so if you do it in 2 layers and get the posterior part of the one that opens up and forms a niche, close that gap, then the likelihood of occurrence is less. The other thing that is important to note, which is very interesting finding, that when you do lower gestation cesarean sections, the cesarean section is slightly higher. They don't have niche. The incision is higher. So what you are saying is if you've got good muscle approximation, then the chances are lower. So it's a fascinating point that we haven't seen niches in lower segment cesarean sections where the term premature cesarean section have been done. So because you will see the incision is higher. And I didn't put an image there, I should have put one, that they're so well approximated because of the muscle thickness. So it is very important point you have raised.
Yes, and how to decide, just one last question, how to decide whether you need hysteroscopy, laparoscopy or both in CSDI?
Actually, I was going
So CSDI, we don't need hysteroscopy. We do the suction, we do ultrasound. In those cases where it's bleeding, we have to put a suture. So hysteroscopy when you're bleeding is not going to be helpful. So that's where the laparoscopic or open suture, whichever you can do, depend upon your skills. So if you are good at laparoscopic surgery, then you can do that. Otherwise, you may need to do it. Once the bleeding has stopped, you may want to check the inside by hysteroscopy, but generally we don't do. When there's live bleeding, hysteroscopy is not the answer. Either laparoscopy or laparotomy.
Yeah, Pragya, please, your comments.
No, actually, I was just wondering that, when doing hysteroscopy, how to remove the lower lip of the, cesarean scar defect. That's
So,
what I was
you
wondering.
have those loops, you got loops to
Yeah.
resect. You use the same loop. It's just like a cup, you're tilting the cup. So the tea in the cup is coming down. So the lower lip, just small slice if you make, it is allowing the blood or fluid to drain out. That's all you're doing. So it's a simple hysteroscopy and resection of the lower lip with a loop,
Can I ask a question, Dr.
One
Lakshmi?
more thing.
Yes, please.
that
Yes, please.
in
Yes, Dr. Jyotika, your comments, please.
No, that was an excellent lecture. Dr. Kamal Oja, I don't know whether you remember, we had invited you for the ISOG in Bangalore. In
Oh,
fact,
hi.
hi. So I wanted to know whether you diagnose cesarean scar pregnancy as early as 5 to 7 weeks, because that is what is recommended now.
Yes, we do that because we have an early pregnancy unit which is very well trained to pick up ectopics. So any ectopics anywhere, and including cesarean scar, is picked up. Once we suspect it, we get an expert to classify it into the 4 categories. And then we do weekly scans if the patient wants to keep the pregnancy, to counsel them. If we are very sure that she wants a procedure termination or evacuation, then we go ahead and do it. Yes, early diagnosis with an expert is needed. We need a second person looking at it.
Yes, and how often have you continued the pregnancy and it has ended as a PAS?
I can't give you the numbers because they go across to our fetal medicine unit. So I'm sorry, I can't give numbers. But whenever a patient says she wants it, then we said like the pregnancy may not continue, but they go to fetal medicine unit. So I can't give the figures.
That was a brilliant lecture. Thank you so much.
Dr.
Thank you,
Kamal.
Lakshmi.
Long time back when I was in England during my training years, I still remember one patient with this kind of a problem used to get so anemic, and she had multiple blood transfusions because every time, and by the time it was diagnosed, it was like, quite late. Every time she would present with heavy bleeding and 2 units of transfusion. And it took actually quite some time, but this was years ago. So perhaps it wasn't so easy, to diagnose these problems at that time.
Yeah, so this condition has come up only 10 years back, yeah.
Yeah. So I think that, the best thing to prevent it is that, we should not be in a rush when we are when we are closing, especially the first layer. We need to be quite meticulous so that we don't miss and we don't. So I think prevention is always better than cure,
Absolutely, yeah.
In
But what you have to
continuation
understand is
with-
that the lower segment is prone to being stretched out in labor. So even despite all your techniques, you may find this defect. So I won't blame the surgeon completely. I'll say it's good to try to prevent. But what I was trying to say earlier is when the cesarean scar is higher up, the chances are less because the muscle is thick up and lower. But lower segment, when it's stretched out, we all know that when we do a cesarean section, in a second stage, the lower segment is so stretched out that you'll find is difficult. And therefore, this happens.
Just 2 questions more, Dr. Kamal, before you log out. Is double layer closure is better or single layer as far as this niche prevention is concerned? And what is your practice? Do you do single layer closure or double layer closure?
So I don't do obstetrics now for the last 6 years, but my team here does single layer closure in the way that they can get the posterior layer and approximate it. But there is a debate going on at the moment that we should do double layer and make sure that if you do double layer but don't take the posterior part, then it's of no use. The main thing is the posterior one, which is inside the cavity, is approximated. Unfortunately, there's a lot of decidua. So despite doing it, the decidua will disintegrate and cause a problem. So that's why I'm saying it may not be only surgery. It may be just a situation. But prevention is better. So try to get the posterior part well approximated. Put your finger in and see while you're done halfway down that you have taken everything. If there's a gap, then make sure you.
Yeah, one more question. How to manage dysmenorrhea and menorrhagia in CSDI?
So as I said earlier, that, the best thing is to tell you, I give them a contraceptive pill back to back for 3 months. So they will not bleed. So the dysmenorrhea is gone, the bleeding is gone. And then they bleed 3 to 4 times a year when they get the bleeding. But because of the pill, the bleeding is less. Some people, they are reassured. They say, Kamal, I don't want anything. I'm fine as long as I know what is going on. So discuss with them and explain why it is happening. But if you can manage to diagnose and discuss it, they'll be very pleased. You will be popular.
Yes. One last question from Dr. Saraswati. Is it so that this is more common after 2 LSCS?
I think it depends upon the cesarean section. As I said, if it's in second stage, it can happen after 1 also. So what I do is I do a dynamic saline infusion sonography in patients who are coming for fertility to assess the defect. And then you'll see the defect. Sometimes I post, as I put saline, it opens up. Because the embryo can get inside it. When you put an embryo, it can go in small. Pregnancy can come and attach at the niche and infiltrate. So these things, the dynamic assessment is 4 millimeter or more. That means the defect is not good. It is a potential. And therefore, the early pregnancy scan in these women will tell you where your pregnancy is. From the picture I put there, how to assess, you can classify that. I'll be very interested in people who can go and look up the records and retrospectively also bring it to Human Fertility or to our IFS journal and bring it. We will be happy to help you in publishing.
Actually, I had one
Do
patient.
SIS for all subfertility patients? That is another
I
question.
do it for, if somebody is coming for secondary infertility, then I do a tubal patency and saline infusion because they may be having secondary infertility because of tubal blockage. So I do a hysterocontrast sonography to check the tubes, flush it, and then I check the cavity also.
Actually, recently,
yes.
I recently had one patient, with who developed an ectopic. It was a case of previous cesarean section, and after embryo transfer, she developed a cesarean scar defect ectopic. She was not so responsive to methotrexate, actually, this patient.
Thank you. Thank you so much,
Just-
Dr. Kamal. You
just can
answered
I-
all the questions so patiently. I'm
Can I
sure
make one
audience
comment?
must have been very happy that you have answered each and every question which were posted in the Q&A and the chat box section. Yes,
Dr.
Pragya, you want- yes,
Can I make one comment?
yes,
It was
please.
a really very interesting topic, and he gave such a nice, brilliant talk and defined it very nicely. And the best part is that he gave the answer that if you are doing cesarean section, you must check it after doing half of that. You have joined both the posterior layers. That is the best thing which we all can do, and remember, and we all can do it. Thank you so
Yes.
much. Thank you for giving me this opportunity to be a chairperson.
Thank you.
Thank you too. Thank you too,
Thank you.
Lakshmi.
I'll leave if you don't mind. Thank you very
Yes,
much.
yes. Thank you, Dr. Kamal.
Thank
Thank
you,
you so
Dr.
much.
Kamal.
Yes.
So we are over with the first session and we had real good interaction with Dr. Kamal. So now we are coming to the second session where the topic is ART pregnancy. Is it different? So the speaker is none other than Dr. Lakshmi Shikhande madam, and to chair the session we have Dr. Sheila Mane madam, the PPH lady who is currently DNB faculty at KGC Hospital, Bangalore, the gynecologist and obstetrician at Fortis Hospital and Bangalore, and Anuraga Nursing Home in Malleshwaram, Bangalore. 42 years of experience in obs and gynae. She also had been the vice president of ICOG. Madam has completed MBBS from Government Medical College and Hospital, Nagpur in 1980, ND OBGY from Government Medical College and Hospital, Nagpur, Fellowship of Indian College, so FICOG. Then Madam has got many accolades to her credit. Madam has also been the area of expertise is high risk pregnancy and fetal medicine. She's very, very well known as the PPH lady. Madam, thank you for joining and welcome to this webinar. The next chairperson is Dr. Madhumati. She is the senior consultant OBGY, Apollo Hospitals, Hyderabad. Her main area of interest is high-risk pregnancy, adolescent gynecology, and president. She is also the president ISOPAV Hyderabad chapter at present. So I welcome both the chairpersons and over to you for this. May I request Dr. Madhumati?
Yeah, I have been already introduced. So please don't introduce me again. But yes, you can give opening remarks. And please send a faculty link to Dr. Sheila Mane. She is posting in the chat box. Email her the faculty link. Yes, Dr. Madhumati. Your opening remarks.
So yeah, it's an honor to be chairing a session, where the dynamic lady is the speaker. With regard to the topic, we all know that pregnancy after an ART is a different ball game altogether. For various reasons, maybe the women already have issues that are going on, or it could be related to the ART procedure sometimes. So here, let's listen to what Dr. Lakshmi has to say about it. And I'm really looking forward to the panel discussion later also, where I'm sure some more, key points will come forward. And thank you, Supriya, for the invite. Thank you, Dr. Lakshmi, again.
Yeah.
Madam Sheila Mane has joined, madam. Good evening, madam.
Welcome.
Good evening. Good evening.
Good evening. And I will just share my screen. No. I'm sharing the wrong screen. Just a minute. Yes. Supriya, is my screen visible?
Yes,
Yes, yes.
yes.
Yeah. So friends, today my talk deliberation is on pregnancy after ART. Is it different? We all know now ART accounts for 1.6% of all infants and 18.3% of all multiple birth infants in the United States. And why I am projecting the statistics of United States? Because in India, we don't publish our results, we don't publish our reports. So as of now, we don't have exact Indian data as far as these ART pregnancy statistics are concerned. Although most of these pregnancies are uncomplicated, IVF is associated with several adverse maternal and perinatal outcomes. And why are these ART pregnancies at higher risk? As Dr. Madhumati was already saying, that these may be at higher risk, maybe because of increased maternal age, pre-existing comorbidities, cause of subfertility itself, drugs used to treat her subfertility. She has undergone some surgeries, so maybe that can be the outcome of previous surgeries, or very rarely the IVF procedure itself. So ART pregnancy, friends, is like kabhi kushi, kabhi gum. On one hand, it alleviates the burden of subfertility on the individual and families, but these also present certain challenges in the form of higher rates of multiple delivery, preterm delivery, and low birth weight delivery. So, can we say that ART pregnancies are different? Yes, they are different mainly because of two reasons. That is multiple pregnancy, but friends, these pregnancies can be at high risk regardless of multiple gestation as well. So look at this study which was published in 2017 on the obstetric complications. The increased risk of obstetric complications from ART appears to apply to not only twin gestation but as well as singleton pregnancies as well, in the form of increased risk of preterm birth and congenital malformations. So I will be enumerating the risk for the mother and for the fetus. So when we are talking of maternal risk in ART pregnancies, it starts from the first trimester, that chances of miscarriage or ectopic pregnancy is higher. It is 15% if she's less than 35 years, 25% if she's 35 to 40 years of age, and it is 35% if she's more than 42 years of age. If she is having multiple gestation, then we all know that this pregnancy is more prone for abortions, gestational hypertension, placental abruption, and placenta previa. ART pregnancies also carry increased rate of obstetric interventions in the form of induction of labor and elective C-section delivery. And yes, there is certain amount of psychosocial impact, especially in ART pregnancies as compared to the naturally conceived pregnancies. Now, what are the fetal risks in these ART pregnancies? There are two, the chromosomal and the multiple births. Chromosomal risk, the de novo chromosomal abnormalities in IVF ICSI babies can occur, especially if it is a male factor subfertility. And if the female age is higher, then of course the aneuploidies in pregnancies adapted for maternal age and number of fetuses. Multiple births, then these babies are more prone for prematurity, low birth weight, and increased chances of neonatal morbidity and mortality. So now what is the best way to protect the mother's health and health of the baby? Regardless of how the pregnancy has occurred, you all will agree with me that is good antenatal surveillance. Why antenatal surveillance? Because by doing good antenatal surveillance, we can triage our mothers into high risk and low risk pregnancy. I know any low risk pregnancy can become a high risk pregnancy at any given point of time. Second advantage of antenatal surveillance is you can screen the fetus for chromosomal errors, structural defects, and growth abnormalities. The third point is prediction and prevention of maternal complications. And of course, if you are doing a good antenatal surveillance, you can decide the time and the mode for safe delivery. Now, when we are talking so much about antenatal care, do we have a standard protocol? The answer is no. No, it starts with continuation of progesterone support, because many of our IVF patients, they come from periphery, they come from other cities, they get embryo transfer done at our place and then they go back to their native place. So when they go back to their native place, they connect with their local OBGYN. So when they are coming to you, you have to see what prescription she is carrying from the IVF center. And the first and foremost is progesterone prescription by each and every center. You have to continue that progesterone in the same dose. How long to continue? It is individualized for every patient profile, but usually we continue it for 12 to 14 weeks of pregnancy. You have to continue the folic acid supplementation, continue the thyroid medication if she is on any, or to make your life easy, please continue with all the medications prescribed by ART consultant till you get a beta HCG report. Yes, when you get beta HCG report and she turns out to be positive, if you want to order certain extra test, please go ahead and order some blood test, but don't rely only on one beta HCG titer. You have to see for the rising HCG titers. Case-specific blood test, I already said, you can go ahead, and hemoglobinopathy screening usually in Vidarbha belt we do. But if you feel that it has not been done and you want to do it, you can go ahead and do hemoglobinopathy screening for these women. Now coming to the OHSS, that is ovarian hyperstimulation syndrome. As I said, they get embryo transfer done at our place and then go back to their native village. So everyone should know the pattern of OHSS and its management. Early OHSS, it usually presents 3 to 7 days after we give trigger. After giving trigger, after 2 days, we do pickup. Then nowadays, if we are doing blastocyst transfer, it is done on day 5. So usually you don't encounter early OHSS, but late OHSS, yes, it presents 12 to 7 days or 12 to 17 days after HCG. That is 10 to 12 days after our embryo transfer. And this late OHSS is induced by endogenous HCG from the trophoblast of the implanting pregnancy. So everyone should be very well versed with the management principles of these OHSS, that is monitoring, supportive therapy. You have to maintain the intravascular volume. You have to prevent the complications, and if it has already developed, you have to treat the complications, and you have to counsel, and counsel. This is in nutshell, I am telling you the outpatient care and inpatient care for OHSS. Outpatient care is very simple. You just have to tell her to limit her physical activities, do her weight daily, monitor intake output, do daily follow-up, and she has to report if symptoms worsens or she gains weight of 2 pounds, that is 1.2 kg, 2 pounds per day. If the symptoms worsens, then you have to admit her and then you have to monitor her intensely with her vitals, with her intake output, daily weight, hematocrit, serum electrolytes, LFT, coagulation profile, and if it is uncontrolled, you have to shift her to ICU and look for renal failure, ARDS, and DIC. So don't take OHSS very casually. Mild to moderate OHSS, you can manage. You all should know who are at risk of OHSS. If she is a young woman, if she has conceived and she is a known case of PCOS, she is having low BMI, then she is at more risk of OHSS. Of course, prevention is better than cure. Now, all IVF centers, in cases of PCOS, they are doing stimulation by antagonist giving agonist trigger and doing freeze all embryo cycles. So practically speaking, we all are OHSS free clinic. But this is about IVF. You can have OHSS even in IUI pregnancies, even with clomiphene, letrozole, though the incidence is very rare. And if IUI is done with gonadotrophin stimulation, you have to be alert and you should be suspicious of OHSS. Now you have documented the rising titers, there is no OHSS, and now she has become 6 to 8 weeks pregnant. I'm sure you all will agree with me that this is the paradigm shift as far as the antenatal care is concerned. Previously, we used to do intense monitoring and surveillance in the 3rd trimester, but now it is the reverse. We have to do intense monitoring and surveillance in the 1st trimester, as some very important complications that may occur later in pregnancy can be predicted in the 1st trimester itself. So the inverted pyramid helps in dividing cases into high risk and low risk in the 1st trimester. Now, either she is with you from the beginning, that is after the embryo transfer, or she has come to you after testing her UPT at home, she is positive. Now she is 6 to 7 weeks of pregnancy. Remember, ultrasound should be done for all ART pregnancies at 6 to 7 weeks of gestation. Why? You want to see the exact dating of pregnancy. We want to document whether it's an ectopic pregnancy, intrauterine pregnancy, or a heterotropic pregnancy, whether it's a missed abortion, whether it is a single, multiple pregnancy, and if it is a multiple, what is the chorionicity. So that is why it is must to do the scan at 6 to 7 weeks of pregnancy. Following ART, the risk of miscarriage may seem a bit higher than in spontaneous pregnancies, but this can be due to earlier pregnancy detection on one hand and the advanced maternal age on the other hand. The major complication of IVF is the risk of multiple births. I know it is directly related to transferring multiple embryos at the time of embryo transfer. So can it be prevented? Yes, if we all opt for elective single embryo transfer. But remember, even if we have done single embryo transfer, spontaneous splitting of embryos can occur, though this is rare. But if this splitting occurs, it will lead to identical twins. What about vanishing twins? In IVF, remember, twins are more often conceived than born. Most twins, they vanish in due course of time. We don't have the true incidence of vanishing twins, but according to one data, around 30% of these twins will ultimately result in singletons and less than 10% will end in complete abortion. If she is having multiple pregnancy, the aim of our antenatal care is, of course, the prolongation of gestational age, to have the increased fetal weight, improve the perinatal morbidity, mortality, and decrease the incidence of maternal complications. So here it has to be a consultant-led team. You just can't allocate these pregnancies to your juniors or resident doctors. Embryo reduction, if it is triplets and more. We don't do embryo reduction if it is a twins. If she is eligible for embryo reduction, it is done after 11 weeks of gestation. Don't forget to manage her with your routine antenatal care, and you have to assess the cervical length and the competency of the cervix and do careful watch for the complications. You have to look for hyperemesis gravidarum, and as I said, inverted pyramid will pick up most of these complications in the 1st trimester itself. How to monitor if there is a single twin demise, or if she gets fetal reduction done and she comes to you for further monitoring, or you are seeing a case of triplets and you are sending her for fetal reduction, you have to do baseline coagulation profile, counsel her regarding prognosis of the second twin. Early delivery is not warranted as preterm delivery may harm the surviving twin. And remember, cesarean section is not indicated in these cases. Even if it is a multiple birth, gestation, but this is an ART pregnancy. So these ART pregnancy twins, they have very good outcome because they are monitored very well, parents are motivated, and doctors also pay extra attention to these pregnancies. Now I am quoting some literature which are the common asked questions as far as ART pregnancies are concerned. What about the risk of congenital malformations? There are various studies. The meta-analysis demonstrate the association between IVF-ICSI and congenital malformations, although it remains unclear if this association is due to infertility or factors associated with the procedure or both. It is also difficult to distinguish the risk associated with IVF alone versus IVF with ICSI. So the Society of Fetal Medicine, V means the Society of Fetal Medicine, recommends a detailed obstetrical ultrasound examination. It should be performed for pregnancies which are achieved with IVF and ICSI. What about the risk of congenital heart disease? Several studies have reported higher rates of total congenital heart disease in the IVF-ICSI pregnancies compared with naturally occurring pregnancies, and hence the Society of Fetal Medicine recommends fetal echocardiography should be offered to all these pregnancies, and we are routinely doing fetal echo at 22 weeks of gestation. Now she has successfully crossed, and now she is 11 to 13 weeks of pregnancy. We all know that this is the time to do nuchal translucency scan, the scan for soft tissue markers and the double marker. Now everyone should know, if this is an ART pregnancy and you are sending double marker, please ask her whether this is the IVF cycle by her own eggs or whether donor eggs have been used. When you are asking this history, don't ask in an open, because this is a very, very confidential information. Even if she's 30 years of age, don't assume that this is a pregnancy by her own eggs. She might be a case of premature ovarian insufficiency. So it is better to ask whether it is self-egg or donor egg cycle. And in case it is a donor egg cycle, then when you are filling the form for double marker, you have to write the age of the donor and not of the recipient. So this is a very, very important point at 11 to 13 weeks of pregnancy. Of course, you will be looking for the vanishing twins. This is the time when we take decision whether she needs embryo reduction or not. Cervical length should be measured. Post speculum examination should be done. In case of any doubt, you can do NIPT. In first trimester itself, you all can predict the chances of gestational diabetes, preeclampsia, preterm labor, placenta previa, and you have to look for asymptomatic bacteriuria and chlamydial infection. What about the cervical length assessment? Asymptomatic single pregnancy, where cervical length is less than 25 millimeter, we don't do routine cervical cerclage, even if this is an ART pregnancy, even if she is having twins and having ART pregnancy, routine cervical cerclage is not recommended. Now, either she is continuing with you or she has come to you when she is 18 to 20 weeks of gestation. Now, this is the time to do a detailed anomaly scan for structural abnormalities. This is the time to do quadruple marker if double marker has not already been not done. If you are sending quadruple marker, again you have to ask whether it is a self-egg cycle or a donor egg cycle. And if it is a donor egg cycle, you have to mention the age of the donor on the form and not the age of the recipient. Here also, again look for the cervical length, do post speculum examination. In case of any doubt, discrepancy, you can go ahead with NIPT or amniocentesis. And as I already said, in all ART pregnancies, we recommend fetal echo at 22 weeks of gestation. Now, what is the risk of PIH in this ART pregnancy? I am showing you the study published in British Journal in 2015. This was a cohort study of over 5 lakh women, which was done to determine the risk of preeclampsia in these ART pregnancies. And after adjusting for maternal age, interbirth interval, and the presence of new partner, women undergoing ART, they had a small increase in odds of preeclampsia. So this should be known to each and everyone. And is PIH more in self-X cycle versus donor X cycle? You all can see what the statistics and the research is saying. Pregnancies which are achieved with donor X cycle, they have more than double the risk of preeclampsia when compared with other methods of ART, that is ART by her own eggs, and more than 4-fold increased risk compared with natural pregnancy. So this is the importance of asking her whether this ART pregnancy is by self-egg or donor egg cycle. Now when we are talking of PIH, can you just give routine aspirin and prevent this? Look at again the statistics. The Society of Fetal Medicine, they do not recommend low dose aspirin in those patients with IVF pregnancy as the sole indication for preeclampsia prophylaxis. You all know, just now I only told you that it is chances of PIH are higher, but just for this PIH prophylaxis, you can't prescribe aspirin. However, you can prescribe if one or more additional risk factors are present, then you are justified in prescribing low dose aspirin. What about PPROM? 2 systematic reviews and meta-analysis have shown that the probability of PPROM is significantly increased after ART pregnancies compared to spontaneous conceptions, both in singletons and multiple pregnancies. Now, what about the risk of preterm birth? A meta-analysis of singleton pregnancies have demonstrated that IVF is associated with higher odds of preterm delivery, low birth weight, and very low birth weight compared with the naturally occurring pregnancies. In addition, the progesterone supplementation, which is initiated for IVF cycles, is not indicated after 12 weeks of gestation if it was solely initiated for IVF purpose without any indication. So how long to continue progesterone support? You have got the answer, that is up to 12 weeks of pregnancy. Now, what is the prevalence of fetal growth restriction, whether it is higher in IVF pregnancies? An increased risk of small for gestational age infants is documented for singleton IVF pregnancies. Meta-analyses have described a higher risk of SGA babies in IVF ICSI pregnancies from fresh cycle compared with frozen cycle. So another term which routine OBGYN should get well versed is whether this is a cycle by fresh embryo transfer or by frozen embryo transfer. Society of Fetal Medicine suggests an assessment of fetal growth in the 3rd trimester for all IVF pregnancies. However, serial growth ultrasounds are not recommended for the sole indication that this is an IVF pregnancy. So this was all about 1st trimester, 2nd trimester. Now she has come to you in 3rd trimester, or now she has entered her 3rd trimester. So what should be done in 3rd trimester? Close monitoring of fetal growth, close monitoring for preterm labor, and you have to pay special attention to the placenta, whether it's the placenta previa or adherent placenta. Why? Because IVF pregnancies are associated with higher risk of abnormal placental shape, placenta previa, marginal or filamentous cord insertion, and placenta accreta spectrum compared with naturally occurring pregnancies. So targeted screening via transvaginal ultrasound should be considered in all IVF pregnancies with filamentous cord insertion, succinturate or bilobed placenta or resolved placenta previa to rule out vasa previa. To cut it short, if it is an ART pregnancy, be extra vigilant as far as the placental location is concerned. You have to see whether it is adherent, it is previa, or there are some other problems with the placenta. It a meta-analysis of 15 cohort studies which compared ART pregnancies with naturally pregnancies. It has been found that the risk of placenta previa is 3 times more in ART pregnancies as compared to the naturally occurring pregnancies. Fetal care, I know we obstetricians are extra careful. If it is an ART pregnancy, you have to do the serial ultrasound monitoring. What should be done in first trimester, second trimester has been already highlighted. In the third trimester, these patients are very apprehensive, but for that matter, for each and every pregnancy, we do advise them fetal kick count. The chances of stillbirth, are they increased in IVF pregnancies? Again, the data is saying that pregnancies which are achieved with IVF, they have 2 to 3-fold increased risk of stillbirth even after controlling for maternal age, parity, and multifetal gestation. So given this increased risk of stillbirth, the Society of Fetal Medicine suggests weekly antenatal fetal surveillance beginning at 36 weeks of gestation for these ART pregnancies. There are various methods of fetal surveillance. We all are doing it, but at home, the most reliable method is fetal kick count. Remember the goals of your antepartum fetal surveillance. It is to reduce the risk of stillbirth, which is 2 to 3-fold higher in these pregnancies. So the antepartum fetal surveillance techniques based on assessment of fetal heart rate patterns have been in clinical use for almost 4 decades, and they are used along with real-time ultrasound and umbilical artery Doppler to evaluate the fetal well-being. There are various methods of doing this kick count. You all can download it from Google, and you have to educate the patient, her husband, and the family about this kick count. Now you have safely reached 39 weeks. So in pregnancies achieved with IVF, does delivery at 39 weeks reduces the risk of adverse perinatal outcomes? Because we should know when to deliver these ART pregnancies. So it is currently unknown whether elective delivery at 39 weeks reduces the risk of maternal morbidity and it improves perinatal outcome in IVF pregnancies compared with expectant management. So what the Society of Fetal Medicine is recommending, that in the absence of studies, we really don't have specific studies focusing specifically on timing of delivery for ART pregnancies. So that is why it is recommended that shared decision making between patients and healthcare provider should be taken when you want to induce labor at 39 weeks of gestation. Everyone knows how to manage these multiple pregnancies and take the care. Now this is $1 million question. This is an ART pregnancy. So whether you should do C-section or you should opt for vaginal delivery. Remember, ART pregnancy per se is not an indication for cesarean section. You have to do it only for obstetric indications. I know, better said, I am saying it, but yes, many IVF pregnancies are asking you LSCS on demand. Muhurat LSCS, I have put big question marks. LSCS on demand should not be entertained. You have to justify why you are doing cesarean section on her. And if you feel that elective C-section is justified, then you can entertain these Muhurat things, but tell them to come with these Muhurat timings between your routine OT hours. We tell them if they are coming with their Muhurat timings at 2 a.m., 12 midnight, 3 a.m., then they have to bring that Pandit also along who has taken out these Muhurat so that they know that elective surgery should be done in elective hours and they should not be forcibly made an emergency surgery in the odd hours of the night. Now, what about the perinatal mortality? Yes, it is 4-fold increased because of the obstetric complications, because of the low birth weight, and because of the multiple pregnancy. Now, don't forget the postpartum care. As soon as the baby is delivered, everyone just rushes and rushes to take care of the baby. They are just after the pediatrician. How is the baby? How is the baby? But being an obstetrician, remember that these ART pregnancies are more prone for puerperal psychosis, lactational problems. You have to monitor the comorbidities in them apart from taking a good neonatal care. So your responsibilities don't end as soon as the baby is born. Severe maternal morbidity is nearly twice as likely in pregnancies conceived with ART as compared with non-ART pregnancies. So this should be kept in mind. So every procedure, friends, it has some inherent risk, including IVF. We have not seen any mother dying just because this pregnancy has been conceived by IVF. But yes, as I already said, because of the comorbidities, because of her increased risk, because of the increased risk of obstetric complications, yes, this mother is at higher risk for increased chances of maternal mortality and morbidity, which should be kept in mind. So what you all have to do? You all have to be very good in counseling. Yes, risks are rare, but they are real and they need to be taken into account when thinking about IVF, using IVF to have a baby. This is for we ART clinicians, that when we want to take any patient for IVF, we have to screen them. We have to see that this mother is fit for pregnancy. But many couples, they downplay or even ignore the risk due to their desire to have pregnancies. But we have to counsel them about the worsening of pre-existing medical conditions, about the increased risk of chromosomal abnormalities, risk of multiple pregnancy, risk associated with advanced maternal age, and of course, about the psychological impact. Especially if fetal reduction has been done, if there is a death of one twin, you have to consider the cost of frequent monitoring. You are calling her for frequent ultrasound monitoring. There is a risk of preterm delivery. It definitely imposes more financial burden on them. And if at all she has to take leave from her job, then she is worried about her job as well. Are there certain medical legal issues? Yes. If you fail to diagnose, if you are doing more tests, if you are doing less tests and you are missing out on some diagnoses, late detection of growth problems. So the list is endless as far as the medical legal issues are concerned. So the key takeaways from my talk is pregnancies achieved by IVF with or without ICSI are at higher risk of obstetrical and neonatal complications than spontaneous pregnancies, and close surveillance during pregnancy should be considered. It remains unclear if these increased risks are attributable to the underlying infertility or to the characteristics of the infertile couple or because of the use of assisted reproductive techniques. Multiple gestation definitely remains a significant risk. So treat each pregnancy as a high-risk pregnancy, have a multidisciplinary approach, and early screening and prediction of potential problems will definitely give you a healthy outcome in the form of healthy mother and healthy baby. Thank you, friends. Thank you so much for your patient hearing.
Thank you, madam. Wonderful talk. Over to Dr. Sheila Mane, madam, for your comments.
Yeah. Thank you, Lakshmi. It was really very comprehensive, and I think everything was included, making it very clear. But as a general obstetrician, whenever like after 3 months, the patient is sent to us, or if we have referred the patient, then the patient comes back to us, and then we have to monitor her. And already, as it is a ART pregnancy, everybody is under stress, the obstetrician as well as the patient. You have nicely pointed out what are the risk factors and all those things. So most of the time, the age also matters, because by the time they decide to undergo IVF pregnancy, they will have PCO patients have insulin resistance, so diabetes, PIH, and all that. So I think it is really, you showed about the reverse triangle of Nicolet's also. So all those things nicely fit into this, because anytime the risk can appear, very few might not have. The one thing is like terminating the pregnancy at 39 weeks. Now, for low risk pregnancy only, there are studies where they are saying that we can terminate or we can induce them at 39 weeks, and they have compared the results and they found it comparable with 40 weeks as well as with 39 weeks. Now, in case of IVF pregnancy, I think most of the time we may try to induce them earlier only, because as there are chances of unexplained stillbirth sometimes, and which is really scary. So you have really explained. Just one submission. I mean, you rightly pointed out the incidence of adherent placenta also. So one thing is even the posterior adherent placenta is common with ART pregnancies and particularly with endometriosis. So if we have a posterior placenta, we should rule out adherence in IVF pregnancies, and for that we may have to do MRI, because as there is so much of overlapping, only ultrasound we may not be able to diagnose, and it should not be a surprise. So I think it is better to evaluate anterior placenta. Ultrasound with power Doppler we can make out, but for posterior placenta particularly, we may have to ask if it is low lying for MRI. That is one thing, but I think you have really made it very, very clear. And most of the time we don't know once we receive the patient at 12 weeks with such a long prescription, that which progesterone we should continue, which progesterone we should omit. I think I would like you to tell us that, because there will be estrogen, progesterone by all routes. By all routes, the patient will comes with that prescription. Yes.
Estrogens are generally given to only the egg donor cycles or in self-egg cycle if we receive less than 5 oocytes. So what if estrogens are given after 12 weeks, you can really gradually, if it is on BD, make it OD and then stop. Progesterone, I already said, again you taper it off, and by 12 to 14 weeks, you can stop the progesterone. Aspirin for all egg donor cycles, all ART clinics are prescribing empirical aspirin 75 gram to all these patients. So please don't stop aspirin. You continue that aspirin, even if I have shown you that slide that for prophylaxis, it is not justified, but don't stop it if she's on aspirin. Folic acid, now the new concept is that please don't stop it after first trimester. You have to continue the folic acid throughout her pregnancy.
But so we have an iron tablet with folic acid. That means
whatever. But you either give iron with folic acid, or if you are giving plain iron, please don't stop folic acid. So you have to continue iron, folic acid, calcium, your protein powder, and then depending on case-specific problems like vaginal infection, cervical length insufficiency, I mean, you have to manage accordingly. But 12 to 14 weeks, practically speaking, you can forget. I mean, you can stop the prescriptions by ART consultant which has been given.
Your experience with pregnancies where you have done reductions, like suppose you've had triplets.
Earlier when I started, yes, I have done fetal, I referred patients, but now we are very, very choosy as far as the number of embryos to be transferred. So we are not transferring more than 2 embryos. So it has really decreased a lot. But yes, it has not stopped totally. So the routine OBGYN should know that triplets pregnancies, the fetal reduction should not be done before 11 weeks of gestation, because there are higher chances of vanishing one of the fetus by 11 weeks of gestation. If they persist, all 3 in good health, then only advise fetal reduction at 11 weeks of gestation.
No, any extra complications they can develop then again during the antenatal period, the patient.
Yeah, if you are doing that, fetus is there, it will resolve spontaneously. So you will be monitoring with coagulation profile. You will be monitoring her like any other patient which you are monitoring with a case of vanishing twin, case of embryo reduction.
There is one question, I think, which route is better for progesterone, whether
vaginal micronized progesterone is the best.
Okay.
Yes, yes. After NT scan only, then you have to figure out which one is, which one should be reduced. That is why I'm saying it should not be done, never should be done before 11 weeks of pregnancy.
Thank you, Dr.
Excellent talk, Dr. Lakshmi. Very nicely covered all the points. It was Very lovely, very nicely done. Thank you.
Thank you.
So now this talk is over. Now, Lakshmi Madam, thank you for the brilliant talk. And I thank the chairpersons, Dr. Sheila Mani Madam and Dr. Madhumati for chairing the session and interacting so well. So now we come to the third session, that is the panel discussion, especially on two cases, that is on scar endometriosis and on IVF pregnancy in 40-year-old women. So to moderate the session, we have Dr. Girija Wagh Madam, who is the professor and HOD Department of OBGY, Bharati Vidyapeeth Medical College, Pune, Senior Consultant Cloud9 and Apollo Hospitals, Pune, Faculty Professor, OGSH International Expert General Coordinator. She is the Chairman, Medical Disorders and Pregnancy Committee. She was in 2012 to 16, then Vice President, India Chapter Gestosis, Member Governing Council, ICOG in 2011 to 14, Joint National Secretary, FOXI, 2010, and she had been the Assistant Coordinator, National Eclampsia Registry since 2008. Now, member Central Supervisory Board of the PCPNDT Act in 2010 to 14, and National Mentor, Lakshya NPCON and the Government of India. Then Anandibai Joshi Award for Excellence in Medical Services. She's been bestowed upon this award. And at present, she is the Vice President of FOXI. So Madam is going to moderate. Welcome you, Madam. And the panelist, we have got brilliant set of panelists. We have Dr. Professor Anju Agarwal. She is at present Professor, Department of OBGY, Vice Dean Academics, King George Medical College, Lucknow. More than 100 national and international publications. She is a very, very active member of this society, past chairperson, North Zone ISOPAB, past president, Lucknow chapter of ISOPAB, executive member, and then vice president, elect North Zone ISOPAB, involved in various research products. Madam is very, very active. Welcome you, Madam. The next panelist is Binu Kushwaha Singh. She is the ex-professor and head department of OBGY, GMC, Shadal. Then she's got best awards in MBBS. She was awarded by many awards. Also, the FOXI's based on Kamini Rao Orator of year 2015. Then she has got many organizational positions, President ISOPAB, and on many other forums also. She has been published so many chapters and did country's first out of OT resuscitative hysterectomy with positive fetal maternal outcome. So we welcome you, Dr. Binu. Next is Dr. Pranay Phukan he is the professor and HOD OBGY Lakhimpur Medical College, Assam, teacher of undergraduate and PG for 32 years. And he has also contributed lots to publications. He is the president of Dibrugarh OBGY Society. Also, he is the president of ISOPAB Dibrugarh chapter at present. He is the chief editor of Handbook of Infertility for Practitioners. And welcome you to the panel. Next is Dr. Amrita Sarkari Jaipuriar. She is a consultant gynecologist and obstetrician, Jaipuriar Medical and Research Center and Garg Hospital, Gorakhpur.
Thank you, ma'am. Thank you.
She is a very active
Hi.
member and had been the organizing secretary of such a very successful conference at Gorakhpur last year. So, and she is awarded with many, many awards and a very, very humble person. Welcome you. Now, Dr. Megha Kamlapur, she is from Karnataka, Gulbarga, Karnataka. In obstetrics practice, she has been for 20 years practicing fetal medicine and high-risk pregnancies. She is the chairman, Fetal Medicine and Genetics Committee, Kasoga, founder president of ISOPAB Kalburgi chapter. This is the recently made chapter that has been inaugurated a few days back. And we are very happy to have you here in the panel. She is a very active member and she was keen on opening this chapter. And thank you so much for joining today. And we love to have you in the panel. So welcome you. Dr. Sunita Jha, she is Director, Sunita IVF Center, Ranchi, Consultant OBGY Society, and she is lead trainer for medical officers in MTP certification course running in the states of Bihar and Jharkhand and West Bengal. Resource person of UNICEF Jharkhand, at present President ISOPAB Ranchi chapter. Then past president, secretary, and many other accolades to her credit. She had been the organizing secretary of E-Zone Yuva Foxy, that was a conference that was very successful, and also the organizing secretary of 24th National Conference ISOPA 2008. So I welcome all the panelists and the moderator, and I hand over the platform to you, Dr. Girija Wagh, madam, for the wonderful panel.
Hi, good evening, everybody. Thank you so much for giving this wonderful opportunity. And I was enjoying both the lectures. They were so very wonderful. And I'm sure now with the expert panelists that we have, we are just going to run through what is called as a consensus for things as I go by. So I'll just share a few slides which I have made so that we are well in place and we don't unnecessarily, waver from our discussion.
Yeah.
And yeah, I think you can see the slides, hopefully.
Yes, yes, ma'am.
Yes.
That I would really want to thank Dr. Lakshmi, then Dr. Supriya for having me here today. And I want to welcome Dr. Anju Agarwal, Dr. Binu Kushwaha, Dr. Pranay Pukar, Amruta Jaipura, Sunita Jha, and my very dear friend Megha Kamlapurkar. She doesn't belong to Maharashtra, but she's very closely, she closely belongs to my heart. So welcome all of you here. Now we are going to quickly go through a discussion of two cases, and this is typically going to be because all of the specialist experts here are clinicians. So I know that we are going to get very, very practical tips because these are something which come rarely in our lives, but they do come there and we require to be there knowing the facts what they are. We all know that scar endometriosis typically when you have a functioning endometrium in a scar tissue, and usually this is found to be related to an iatrogenic cause such as an incision, and that is where we really get into problems. As I mentioned earlier, it's a very, very rare thing to have. Prevalence is typically seen in the scar of a C-section, about 0.03 to 1%. And among this entire scar ectopics, only 0.3 to 0.04% are post C-sections, and usually the diagnosis is confirmed by histopathology. So coming to Dr. Anju Agarwal, I would like you to give my first answer here and look at this case history, and all of us can actually come in for this. We had this 43 years old married woman complains of pain in the site of C-section, which she had undergone 7 years back, and actually 8 years back. And then for the first 1 year, there was no symptoms, but after 1 year, she started having some swelling there, and every time she menstruated, it became prominent, painful, and it used to subside in the beginning. Later on, gradually, she started to take painkiller medicines. And then finally, it went on increasing. Now, what happened was the C-section history, as basically, this patient had not come to a gynecologist. She had come for a surgical excision, directly advised by her doctor who had first seen her wherever she was consulting. And he said, now you go and get it removed. And so she didn't come to gynecologist, she came to surgery. But since ours is a multi-specialty hospital, naturally, we had a being referred to us. And then we took a detailed history because you can understand that surgeons don't take such a detailed history as we normally take. And therefore, she had undergone a C-section for antepartum hemorrhage at her hometown. And then after a year or so, she resumed menstruation, gradually developed pain and feeling of lump, initially at the left side of the scar during menstruation for last 7 years. And initially, the pain appeared 2 days prior to menstruation and continued till second to the third day. And it was typically burning type, non-radiating, and confined to the site of the palpable lump. So this is the typical finding. As you can see here on inspection, you can see that there is a lump here about 2.2 centimeter nodule. On palpation, it is immobile, non-reducible, non-compressible mass. And there was a dull note on it, and there didn't seem to be anything below the skin attached to this particular lump. So, Madam Anju, what would be your diagnosis on this patient?
So, thank you, Dr. Girija. And yes, you have presented a typical case of scar endometriosis with the typical history that the pain is at the time of menstruation, which many times we may not get. We may only get a history of pain which sometimes increases during periods, and a very typical lump. So most probable is definitely scar endometriosis. And we'll like to do an ultrasound to confirm the diagnosis.
Yeah. So according to you, as you rightly said, that it is a scar endometriosis. Dr. Megha, would you want to comment on any differential diagnosis with these findings? You are not audible. Please increase your volume.
It can be an abscess or it can be a sebaceous cyst which gets infected. Sometimes it can present as a lipoma, or sometimes it can present as a fat necrosis which causes severe pain, and as you have mentioned, stitch granuloma.
Yeah.
So we definitely need the help of ultrasound to differentiate it.
Absolutely. So the confirmation would come by the ultrasound, as you mentioned. Dr. Amruta, madam, can you just tell us as to what would be the characteristic findings on an ultrasound? Because you know what happened? She did this ultrasound. When the doctor sent her to the surgeon, she was told to have small cysts in her both ovaries and some pathology in a previous scar site, and was therefore advised to go to a surgeon for a surgical excision. So what should we look for an ultrasonographic finding onto this scar?
Ma'am, there's usually a rim, and we can see endometriotic tissue in between. And I mean, it is a hypoechoic area with hyperechoic, some hyperechoic lesions also in between, and fluid also. I mean, and there's a rim in this lesion. On the ultrasound, we can find it. It is inhomogeneous, I mean, both hypoechoic and hyperechoic.
Dr.
And
Pranay, sir,
it
would you
is,
want- yes.
and
Dr.
it is the tissue, I mean, it can be seen infiltrating in the surrounding tissue also. And one more condition can be a differential diagnosis of this scar endometrioma. It is a desmoid tumor, which can present as.
Can you just tell us something more about the desmoid tumor, madam?
Ma'am, it's a fibromatosis kind of a thing, and it spreads in the tissue. It is a fibrous tissue which spreads in between the muscle layer and the layers of the abdomen, the scar.
Just wanted to ask all of you experts. You must have dealt with few scar in endometriosis. Have you seen it typically that it's on the left side very commonly than the right side? I know everybody's trying to imagine this.
Yeah, yes, ma'am. Yes, ma'am.
Anybody knows the reason for this? Why it is more always on the left side?
The patients that I remember almost the right side than midline. But left side I don't remember.
Yeah. Typically, either in the middle or in the left side.
Yeah, and even things that might happen to the left side. What's any scientific explanation?
I really don't know what is the scientific. Basically, we don't know itself why this scar.
I just want to say this scar endometriosis is okay, but we get in the skin. But I got 2 cases of endometriosis in the scar of the uterus, you know. That is a uterine scar.
Oh.
That means recently I operated and I have removed this scar, and the histopathology was endometriosis, which was the patient had abnormal uterine bleeding and responding to sometimes to progesterone, but when progesterone is stopped, patient starts bleeding again. Like it AUB coin type, the last one, that not yet classified. And then I did a hysteroscopy. I found that there's some granulomatous tissue there, and ultimately thought that this can be removed by hysteroscopy, but I could not because the bleeding was there. Ultimately, did a small laparotomy, and I have found out and removed the scar. And when the scar was sent to histology, it's a case of endometriosis of the uterine scar. And this is the second case I got. Yeah.
Oh, so that's something. And I think as now the C-sections are going high and high, we will be able to experience
like
this more.
Is increasing the same way the endometriosis of the uterine scar is also increasing. In the last 2 years, yeah.
Any more, Megha, you would want to comment on any ultrasound findings where typically we would like to look at this?
These lesions will not have any vascularity, and, capsulated as we see in fibroids like that. So typical absence of vascularity will be also
Yeah, I think because of the very high resolution ultrasounds that we are using, we are lucky that we are able to diagnose this properly. So I think the insistence has to be, and there has to be a strong suspicion why you should do it. And that is how you must have seen that we did a sonography on this patient, and it was found to have a solid hypoechoic inhomogeneous texture with internal scattered hyperechoic echoes and speculated margins, which were seen infiltrating the surrounding tissue.
Yes.
Now, this patient also underwent an MRI. Do you think it's really essential to do an MRI in this patient? Anybody would like to comment on this?
This typical clinically diagnosis is sufficient, I think. Then
Sufficient, absolutely.
the unnecessary the abuse of investigation should be done to just to diagnose a case of scar endometriosis.
Yeah,
Not-
and I don't know how many doctors themselves have undergone an MRI study. It's quite scary, actually. It's very easy to say do an MRI.
Costly, scary, and then unnecessary.
Yeah, costly. And many times, if you have sonologists like Dr. Megha having the probe in their hand, you will get your diagnosis very much with clarity. And even like all of us train ourselves to use our ultrasounds better, we really do not need to take an MRI. But
Yeah.
sometimes there can be confusion. Like, let's see, many times there are some tracts. We are not sure where it is extending. Is it extending to the previous scar? Is it extending to any other structure? So that would probably give us an inkling that maybe we require to do so, as you are
Yeah.
all experts classically saying that it's not should be an immediate next step investigation, but it should be done and guarded only when we find some ambiguity in our baseline thorough ultrasound that we have done. And we had a very beautiful lecture by Professor Jha from UK, and he did mention that you should do the scan in such an appropriate way that you are properly tracking the tissues. And I think as we gynecologists, we are doing blind pervaginal examination so wonderfully. Passing on the probe should not be a great challenge, and that could help us in identifying the tissues correctly. And then, of course, we can take help of the color Doppler, or maybe consider doing an MRI. Dr. Binu, madam, would you want to comment on what we have been discussing?
I mean, ma'am, we are going on right path. Everything is going fine.
Any comment on MRI?
I totally agree upon whatever you said, whatever other panelists said. And MRI is, in this case, at least it is not required.
Okay. So now this was the diagnosis that we made. So Sunita Jha, madam, what should we do next?
Yes, ma'am. Then we want to excise that particular nodule, what we have seen in this picture.
Yeah.
We'll try to do.
Are there any principles that you should follow while you're doing a wide excision of a nodule? It's a very superficial thing, fortunately, in this patient, as you can see.
Yes, ma'am.
It's not as complex as Dr. Pranay was saying that it's going into the scar or anything. So we are lucky. So then what would we do? Any
Yes,
principle?
it should be an extensive surgery. We want to remove that. I think the other layers reaching up to the layer.
Yeah.
Because, madam, we remember that there was one case in the earlier time when we are doing a longitudinal incision, and as was the doctor's wife, and she was having a regular complaint of only pain during the menstruation, and she only तभी उनको ठीक हुआ when we did a hysterectomy even of a single baby. We offered a hysterectomy, then only she is relieved of that pain, dysmenorrhea.
So in this hysterectomy was done along with an oophorectomy?
No, madam. At that time, she was having only
she was young.
Regular pain, and she only relieved with all medicines. She was not only not able to relieve her. Yes. And finally, because she was a doctor of our own colleague, a wife of our own colleague, so we sent her to AIIMS, and they did a hysterectomy, and then only she is relieved of everything.
Oh.
It was so serious.
So no medical management helped her.
Help her, yes, ma'am. So it's a wide excision.
Yes, sir.
Around
just when the lesion is small, sometimes the patient is not ready for surgery, and she is around 44, 45 years.
Yeah.
And can we go for some medical therapy in this particular patient? Is there any
I always do that as a first choice. Now
Yeah.
here this patient had come to the surgeon with all preparedness, and then many times you can't be giving them ambiguous opinion. And she was suffering from 7 years. So
Yeah, no,
maybe this
definitely have
was
to
a
go.
justification. But
Yeah.
yes, you rightly said many times we can use a lot of medication. That was we were going to come. So this patient underwent a wide local excision. You can see the mass of about
Yeah.
here 4 to 5 centimeters, and then on cut section it is typically showing the endometrial tissue, which was confirmed by the presence of endometrial glands lined by benign endometrial cells, and it turned out to be endometriosis scar. Now,
Yeah.
anybody can just try to tell us what could be the reason of this scar endometriosis. Any reason behind it? Why would it happen?
Ma'am, spillage, like at the time of cesarean section, there would have been spillage of the blood and decidua, which
Mhm.
must have undergone, taken its path into the tissues, or it would have stayed in the scar and then grown with the vascularity, etc.
Exactly. If we just see the causes of
Implantation, yeah.
Yeah, and
Yes,
causes
sir.
of so many theories are there. And
Ah.
here I the implantation theory as well as the immunological theory. Also
Yeah.
some genetic aspects are also there. All patients are having this procedures, but only few of them might have this problem. It may be associated with immunology as well as the genetic things.
Yeah, because probably their immune system is not able to clear it off.
Yeah, yeah.
The iatrogenic implantation which is getting transported, because as you typically see, the decidua is actually sitting in the uterine cavity. Why should it come out and cause endometriosis on the scar outside and do nothing inside? Because we may be able to justify this in Dr. Pranay's experiences of 2 cases on a cesarean scar endometriosis.
Cesarean scar.
But for an external scar, or sometimes even we have it on an episiotomy scar, it's really surprising how it happens. And therefore, that it may be an immunological theory also, where women are not, in any case, as the experiences with C-section are going to keep on increasing, because I must share something else with you. A little digression from what I'm saying. But two of my very dear colleagues, like my same age, now we are 57, 58 years of age. Just about 3-4 years back, for no reason, they had pervaginal bleeding, and which is torrential. One of them underwent an emergency hysteroscopy, and she had undergone a C-section for which she required to be, there it had to be ligated. There was some sort of an AV malformation.
Yeah,
And
that's
the
quite.
other one kept on bleeding, and it was diagnosed to be an endometriotic scar on a C-section.
Yeah.
Imagine their C-sections were done quite 25, 28 years back. So we must always remember that, long-term issues also can occur. And therefore, maybe we must start using and guiding them for some preventive issues also, which are necessary. And I'm sure their C-sections that time must have been done for an indication, isn't it? Like nowadays, sometimes we say, thoda sa lax ho gaye hum, IVF pregnancy ho, koi special situation ho, we will say go in for an elective section. But our patients demand also. So are there any other sites which the experts have experienced? Now, Dr. Pranay told us about cesarean section scar itself on the uterus. I showed you a case on the skin. Anybody? I've also seen one on an episiotomy site. By the way.
Yes. Episiotomy.
Anybody has tackled any of this scar endometriosis?
Same.
Dr.
Cesarean scar.
Umbilicus.
Umbilicus. Okay, yeah. And typically, post laparoscopy, usually it will happen, right? And nectopic pregnancy, and you really don't know, and especially when it happens in the laparoscopy site or an umbilicus. So, Megha have made a change and have stopped taking the incision, the exit point from the umbilicus long time back. So you just take it a little above.
Oh, yeah.
Or maybe just at the lower limit, don't take it inside. And because it may cause us a DD about tuberculous cheloní is another very important, terrible infection, which can happen in laparoscopy, and you really don't know what it is. Anybody else has experienced any such ectopic scar endometriosis?
Yes, ma'am. Scar endometriosis. One experience with me is that she was not willing for a surgery when I advised her. So I gave her injection leuprolide. 3 injections were given at the difference of 28 days.
Correct.
And she developed amenorrhea, and within a few months she came back with pregnancy. She had a third child after that. She had 2 previous cesarean sections, and then
So
the
these
third
are
time she
all our
delivered.
miracles of treatment, and sometimes we do connect to the pathology. Unfortunately, it cannot be published in any randomized control trial, and
Yes,
therefore
ma'am.
it remains as an anecdote experience, but something that we can definitely try for these rare situations. As we see that there are a lot of options that we have, typically the combined oral contraceptive pills, the Dynogest, which is now come on the market, the NSAIDs, which we can typically tell them to take during the painful periods, LNG-IUS, DEMPA, and now, as you said, Leuprolide, which can be taken. Anybody wants to comment on any of these treatments for
Yeah.
scar endometriosis?
COC, Dr. Giza, the COC containing Dynogest and ethinyl estradiol.
Yeah.
I think this is a new addition to the oral contraceptives.
Armamentarium, correct.
Become of Dynogest, I think it is helpful, and
Yeah.
it women the regular cycle, she is also happy, as well as also acts on the endometriotic tissue. We can try the COC in that particular patient because cost is very low, almost probably 1/3 or almost 1/4 of the Dynogest therapy.
Dynogest.
Yeah.
Can be used, of course. It can be used continuously also because of the low cost.
Yeah, because I think we should now start making our patients used to this particular approach. As you heard Dr. Zah saying, that they use something like a seasonal. So they give back to back for 3 months, they give a COC, and that woman will just have 3 periods in a year. So then
Yeah.
that will automatically take care of so many illnesses. And like as Dr. Anju said, so they want to become pregnant, they just stop that medicine and they can conceive.
Exactly, yeah.
So that is an option that we have. Anybody, anything else anybody would want to comment on of the medical managements?
I was just wondering if LNG-IUS could treat this scar endometriosis because that basically acts locally, and
Yeah.
would the amount of progesterone be that much in blood that it is going to treat scar endometriosis also?
Completely
Because
agree.
I don't have any experience with the
Yeah,
LNG-IUS.
absolutely. Completely agree to it. There are very few anecdotal cases or, experiences which have been mentioned in the literature. While,
Maybe as sir said, the case of scar endometriosis on uterus itself. Maybe in those cases it may.
or maybe post-operative, you have done the excision of the scar and the niche, and then you may consider putting in an LNG-IUS.
Yes, yes, yes.
But there is a problem. Another problem with LNG-IUS or giving any progesterone therapies, it definitely causes a lot of thinning of the lining of the uterus. And I wonder whether that too much of thinning, how it will behave in a already injured uterus. With all these things require to be thought, what we really need to do. And we must keep on looking at the location and the patient's age and the response, and then tell her that you have something very untoward and very rare, and therefore we have to be maybe experimenting with you to give you the right results.
And
Yeah,
yes, I
basically-
just wanted to add, why can't we use norethistron? I have used norethistron also in my patients, and it responds well. I mean, I have a lady
long-
who has been taking it for last 4 months.
No,
Yeah.
long use of progesterone is a hepatotoxic. So you have to check the liver function test regularly when you are only progesterone like norethistron or
But
methoxyprogesterone.
that happens only if it is used for more than 2 years or something. I think that is there in a study.
No, it varies from patient. Sometimes after
Right.
use for 3 months also you might get a deteriorating liver enzymes, but in some
Right.
cases, right, it varies from patient to
See,
Yes,
as you rightly said, sir, and both of you, what you're saying is something very wonderfully that you're discussing is, the concerns about a long-term therapy. Now, another entity which has come up, which we have to be very aware of, is the NASH. A lot of women today we are seeing as having non-alcoholic steatotic hepatitis. And therefore, when we are writing any progesterone therapy, any COCs, I think we should be a little careful and then consider.
Exactly.
Yeah.
Well taken. Yes, ma'am.
Likewise, DEMPA, I just wanted to share with you in fact, 2 experiences of DEMPA. When woman had come with endometriosis, we had done a laparoscopy. Then that time the treatment to be given was Leuprolide.
Ma'am, have some water, please. Have some
Yeah,
water. Yeah.
So this was something which she could not afford. So I gave her Dempa, and then her amenorrhea continued and she simply became pregnant.
No, Girija, no, for poor patient who cannot afford Leuprolide, at least the DMPA for 2, 3, or 3 or 4 injections under close observation.
Yes.
Yep, the LFT, and you can continue it. It is not usually for poor patients is okay, and we are also using poor patient who cannot buy the Leuprolide for 3,500 or 4,000 rupees. Hardly two, probably 1 ampoule of DMPA. It equally, the efficacy is almost same.
Absolutely. We can even give a 300 mg at once, 2 injections.
Okay.
Yes, that I have been doing.
Okay.
Yeah.
But I think 150 is the preparation.
150. She
So
said 2
injections,
injections.
actually, 2
She said 2 injections.
Yeah.
The maximum dose can be up to 450 also, if you decide.
Set dose. Set dose.
Can I share something about Dempa?
Yeah, sure, ma'am. Sure.
Yes, madam. Yes.
Just wanted to say that I have seen one patient, still saying that she was having pain during periods and already completed her family and didn't want to, very young. So I gave her Dempa and she stopped menstruation. She got amenorrhea for almost 3 years. I was just wondering what has happened, but she was happy with it. And then after 3 years, I said, no, I'm not going to give you now. So go to COC. And she took COC for 2-3 months. Again, she said, no, I want Dempa only. And again, I gave her 1 shot of Dempa. And she again is amenorrheic. For, I think now it's almost more than a year.
Yes,
Just by
yeah, but because these are the things which our patients call the shots, basically. If they are happy with it, we are happy with it as well. But there are so many women who do not understand the importance of not having periods. There's so much, advantage in not having periods.
Right. And one more thing, just wanted to share about Dynogest, that it is really very costly. But if you want to use as contraceptive, then the free days is better. I mean, that is the very cost effective one.
Yeah, that was what Dr.
Yeah.
I know I'm coughing, but I'm surprised how Dr. Pranay is also coughing. Itna contagious nahi ho sakta apna Zoom platform. So now let's come to case number 2. Thank you. So case number 2, we are just going to go quickly only through what are the consensus statements. So because we had a very wonderful talk by Dr. Lakshmi, and I don't think anything more has to be said, we are only going to speak about the age-related factor where IVF pregnancy in a 40-year-old patient is the cause of concern. We all know, because these patients, either they are pregnant because of an OD, they have taken a donor oocyte, or they have had some background problems, or they develop some problems, and then pregnancy outcomes, including aneuploidies, are very high. And whenever we talk of advanced age, typically it is 35 years or beyond. And there have been studies such as the FASTER trial, where first and second trimester evaluation of risk was done, or the National Birth Defects Prevention Study, which demonstrated significant association between aneuploidies and all. And then other risk factors in these women were also identified. So when we look at this chronic medical conditions, hypertension, obesity, which happens in these women, it's been found that progressively as the age advances, the problems also advance. So today we are just going to have a Q&As for perception of experts as to what are these issues and what are the consensus and what are the evidences. For example, antepartum care. Now, pregnancy with anticipated delivery at age 40 years or older be recognized as a risk factor? Do we recognize it as a risk factor?
Yes.
Definitely.
I think all of us agree.
Yes.
For adverse maternal, fetal, and neonatal outcomes when counseling patients and determining management plans. And there has to be a nuanced counseling which will be dependent on specific age and the associated comorbidities. So do we agree to this?
Yes, ma'am.
Yes, ma'am.
So they have to be categorized as special patients, but you'll see what is the evidence. It's just great to see a very weak recommendation and a low quality of evidence. So I think we must start writing more papers so that this will improve the consensus to what we are saying. So should we give, Dr. Lakshmi was saying that don't give empirically too much of low dose aspirin. But in these women, daily low dose aspirin for reduction of preeclampsia for pregnant individuals age 40 or older in the setting of at least one other moderate risk factor. It's not more than 2 risk factors or otherwise, but should we start them? Now she would come to us with a pregnancy, says, oocyte donation hi hua hai mujhe. We know that if there is an OD pregnancy, chances of she having preeclampsia are nearly 50% or more.
Yes, ma'am.
Or maybe she is a obese woman or she is PCOS or whatever. So in such patients, would you want to start a daily low dose aspirin the moment you confirm the pregnancy at 6 weeks itself?
Yes, ma'am. And we should also know the gestosis score. I mean, we should go through the history, the family history also. If the mother was diabetic, if the mother, her mother, the patient's mother was hypertensive, etc. So we should see that. And also of course, you talked about the obesity part and the
I said
patient
any
herself.
other, even one moderate risk factor is there, I guess, apart from the fact that she's 40 and she has one more risk factor who would be happy starting her on a low dose aspirin.
Yes, ma'am.
Yes,
All of us
we
agree?
are happy.
Yes,
Yes,
I would
ma'am.
like to
Yes,
start
ma'am.
at 12 weeks rather than 6 weeks.
Okay, you would want to start it at 12 weeks rather than 6 weeks.
No, considering
No,
this,
I did-
I'll start her with
Six.
No, no.
6
Ideally,
weeks.
ideally, it should be started as early as possible.
As
before
early as
marriage.
possible.
Yes.
Of course.
If-
Yes, sir.
and it should be started. Otherwise, 12 weeks, there is no use because we want to get from
complete dose of 150, not 75.
Yeah,
Yeah.
Complete
150
dose of
definitely.
150 as early as you diagnose the pregnancy,
Yes.
maybe at the cardiac, because we want to give her an advantage of proper implantation.
Regarding the dose schedule, I have my own experience. Like that when the weight is less than 60 kg, I give 75. More than 60 kg, I give 150. But there is no, I mean, consensus like that. But usually I do that. Low weight, I give for low doses, and then more than 60 kg, I go for 150.
You are very lucky to have. You are very lucky to have such thin patient at 40. We are not so blessed.
300 kg is the dose, so it comes 150, at least 50 kg only.
Madam, in the cases of repeated implantation failure, if you are preparing for the next implantation, also in the FET cases, we do give in the preparation phase also.
Yeah, I understand you, Dr. Krishna, but apna aaj ka challenge hai only 40-year-old IVF conception. बस तो वो RPL BPL में नहीं जाएंगे आप.
40 में भी एक बार में नहीं हुआ तो सेकंड में देने का.
हाँ, ठीक.
So, no, coming back, I'm sorry. So this has a grade 1B strong recommendation and a moderate quality evidence. So next statement. Given the increased rates of multiple gestations for pregnant individuals at the age of 40 or older, we suggest a first trimester ultrasonography.
Definitely.
Yes or no?
Yes, it is
For
suggested.
yes.
I think all of us do.
And it is
All,
IVF also, and then yes.
Do you do it again at 9 weeks or do you directly jump to 12 weeks?
9 weeks for the first.
9 weeks, yes.
I think we all do it as a dating scan once again. At
Yes,
9
ma'am.
weeks.
Yes.
Very high rate of miscarriages in these patients.
Yes.
But the important thing is that we should enter the age of the donor if it is donor conception. That most of the time it is forgotten, and LMP is entered in the machine, not the embryo transfer date. So we have to be very careful about that.
Please repeat it, Megha. Please repeat, Megha.
Instead of entering LMP in these patients, we have to enter the date of embryo transfer, that is date of conception in the ultrasound machine to get the exact gestational age. And second thing is, we have to inquire specifically, as Lakshmi Madam has told, that is it a donor embryo, and we have to enter the age of the donor.
Absolutely. What a wonderful guidance you gave us. That's very important. So this is having grade 2C, weak recommendation and low quality evidence. So Megha, you have to publish more cases. Now coming to PGT, serum screening with or without nuclear translucency or cell-free DNA and diagnostic testing like chorion villus sampling or options we discussed and offered to all pregnant individuals, regardless of age or risk of chromosomal abnormality. And every patient is also given a right to pursue or decline prenatal genetic screening and diagnostic testing. So now this is open to
Definitely.
the house. What are your preferences? If a 40-year-old IVF conceived has come to you for booking, so would you do a cell-free DNA in all your patients?
Yeah, NIPT should be done in ultrasound plus NIPT. It is not the double marker or anything. We should directly do a NIPT at around 12 weeks of pregnancy along with the NB and NT, nuclear translucency.
Proper pre-test counseling actually. I would say because double marker test also has got its own advantages other than diagnosing aneuploidy.
Yes,
So
ma'am.
I would say we should counsel her first. Pre-test counseling is very important.
So one is
And
counseling,
also the
but then
cost
what do we
factor.
offer? Patient says, doctor, मैं अभी first time मेरे life में pregnant हो गई, तुमको जो करना है वो करो.
So I
मुझे
would
I
go for
want
double marker also.
Double.
Because it gives you the risk of NABs and developmental
Double marker
issues
and
of preterm labor.
NT-NB scan.
So PAP A and beta SCG will help us for that. I will tell her that you being a high risk case, and 40 years, it's better to go for NIPT, which has got 99.9% of positive.
Double marker.
But
Then what
we
is the
need to explain her about the possibilities we can diagnose by CVS also. So I think the counseling is the most important part. See, in CVS also the chances of losses these days are very less. So that would give her a proper genetic diagnosis, and then and this NIPT is going to tell her only about 3 chromosomes. So the thing is, we should leave it on the lady. We should counsel her properly about the NIPT and the CVS both at this particular age, because she's already 40. There are very high chances that she might have.
So I'm coming to agree to all of you that NIPT in all. Okay, NIPT when? 12 to 14 weeks or 16 weeks?
12 to
We
14
do
weeks.
that. We do it on 16 weeks, ma'am. 16 weeks onwards.
Earlier.
That will be better.
Yeah, I will do it earlier. Perhaps it should be done in early pregnancy as 10 to 11 weeks, when the concentration of cell-free DNA will be more. So as the age advances, the concentration will come down, and we'll supplement that with the double marker and NT scan. So by the time NIPT report is available, we'll be having NT scan report with fetal structural anatomy scan in our hand.
Yeah, as you brought this
patient-
part of availability of that chromosome. If the lady is obese, then there is a reason that we should delay the testing. So it depends on her BMI also then.
Yeah, that is why we have to customize the approach. If the lady is obese, we have to do pre-test counseling, and then
we can delay it
for reason.
16, 18 weeks.
Okay, so now we come to a consensus that all patients will be subjected to a dual marker test along with the biomarkers, uterine artery PI, and trying to look for any structural aneuploidies, which many of them are seen at that time. And
May
we also do
May
the
I say something, ma'am?
No, 1 minute, Dr. Girja. So do you think that if we do NIPT and then NBNT in the nuchal translucency and the nasal bone along with the ultrasound, and then why should you go for double marker? Why the extra 3,000, 4,000 rupees cost we should give to her?
Double marker is done along with PLGF. PAP A and beta SCG will give us the risk for preeclampsia, preterm labor, abruption, IUFDs, and FGRs.
So all these are there risks in this woman. So therefore we would be justified in a 40-year-old with an IVF.
You should at least tell her, yes. That.
May I ask one question, ma'am?
Yes.
Ma'am, most of the patients who have undergone IVF, the IVF labs, many of them do a pre-genetic testing of the embryos before transferring. So even such patients would need these kind of testing. I mean the NIPT, etc.
I am sorry, I don't have an inclination. Anybody can answer this question? Because I am really doubtful about what pre-genetic testing they do. They do screening for aneuploidies only. They wouldn't be able to do screening for the other things that we are talking about, preterm delivery.
No, ma'am. That's true. The dual marker and quadruple marker, I agree, ma'am. I'm just asking about
they are
the
considering
cell-free DNA.
They are just speaking about it, that they can do microarrays on the fluid in which the embryo is and all that. But how much is it reliable? We really, time only will tell us.
That was my question, ma'am. It was not a comment. It was just to know.
Megha is saying something is recommended.
There is
even in
family
these
history of some
cases.
genetic diseases. So they can definitely go for single gene disorders.
Yeah.
if
So
they-
those may
and
be
thalassemia also. Thalassemia also.
thalassemia. No. So grade 1A strong recommendation, high quality evidence exists. So we can recommend all this without feeling guilty of spending patient's money, and she can be advised. And if she refuses, it's fine. That's her choice to make. And these are the incidences, as you can see, as the age of the woman increases, you can see there is a very high risk, much increased risk of all these kind of abnormalities that are there, and many rare chromosomal abnormalities, and therefore it's justified that you do these testing. Now, coming to the detailed fetal anatomic ultrasound, given the increased risk of aneuploidy and potential risk, should we do a TIFA in all these patients when you have done so many things by 16 weeks already?
Yes.
Yes,
Yeah.
ma'am.
Yes.
Yes, ma'am.
Now, this has a weak recommendation and a low quality evidence, grade 2C, but all of us will do it. Now, growth scan. Should we do a growth scan in these women? Because there are very high chances of LGS and HGS.
IUGR.
ma'am.
Yes, ma'am. We'll do.
Weak recommendation, again, low quality evidence, but we will still do despite we doing clinical examination. Would you offer antenatal fetal surveillance for pregnant individuals with anticipated delivery at age 40 years or older, given the increased risk of stillbirths? You can see in this graph, and this
Yes.
graph is from an ACOG publication of 2006, which is AJOG, and which is showing that it is such a high incidence. So should we do a fetal surveillance in this patient?
Yes.
Yes, sir. Yes, ma'am.
Yes. So grade 2B, weak recommendation, moderate quality evidence. Birthing decision. Now, Megha told us very categorically, please do the proper dating. So that's very important first step. So then we know exact gestational age of this woman. So delivery in well-dated pregnancies at 39.7 or 39.67 weeks of gestation for individuals with anticipated delivery at age 40 years or older due to increasing rates of neonatal morbidity and stillbirth beyond the gestational age. Should we do?
Yes, yes.
Yes.
Usually,
In
ma'am,
case
those
stillbirths are
patients
more
gives
common
us
in the
symptoms
Asian.
after 37, usually in the singleton pregnancy. In the twin pregnancy, up to most of the delivered within 36 weeks. Some symptoms starts like leaking and is there. And even in the singleton pregnancy, we have seen that 37 plus is only, most of the patients doesn't reach up to the 39 week and plus weeks.
I think that anxiety and the nature takes
Yes,
over.
ma'am. Yes, ma'am.
So we don't have to think so much.
Yes.
But all the same. And then the last question, I guess, is route of delivery. So should we do a vaginal delivery or a C-section?
If there is no straight away obstetric or fetal indication, we can definitely at least try for a vaginal delivery, but with a counseling, proper counseling, because there are bone changes at this age. At 40, I won't say much, but then yes, there are chances of NPL. The literature says that the labor progress disorders are more common in these ladies. So, but with a close surveillance, we can go for a vaginal delivery also if there is no other contraindication for it.
Yeah, so
Then
I
at
think
40
very,
years-
very properly monitored an ideal case who doesn't have any comorbidities, maybe she can be considered for a vaginal delivery. But we are not so blessed. Many times they will come with some problems.
Nobody's doing it.
And you can see here, this is a study which I thought I'll get it out of interest in delivery among women 35 years of age or older. By a comparison was done between elective C-section and a planned vaginal delivery. Of course, it's a retrospective study where 35,000 odd in C-section and more than 4 lakh women in vaginal delivery were compared. And they still continue to find out that C-sections are associated with morbidity and mortality.
But
Bhagwan.
maybe this can further be stratified like 40 years or more, 45 years or more.
Yeah,
Like,
but then if you look at the first line on this study is in hospital death, 25.6 compared to 4.4. So I know we कितना भी हमको मुझे खुद को ऐसे लगता है कि why go through so much of pain, do a C-section and get rid of things. Anyways, एक ही बेबी होने वाला है आपको, हम सब ऑप्टिमाइज करके आपको अच्छी तरह से है ना get in and get out केस करके देंगे, लेकिन the statistics is not speaking in favor, and therefore we have to always be guarded and counsel the patients accordingly. So it is great to be strong recommendation, moderate quality evidence. So thank you, everybody. I
Thank
think
you so
Madam, I feel
enjoyed
we
it.
should modify some of the evidences, madam. And I, by the next webinar, you will come up with new guidelines. Thank you so much for being.
Thank you, all of you. You were so brilliant and you made it.
जो ये study आपने मतलब क्या था?
This was very interesting, ma'am. Yes, the last one, the last study.
Yeah.
So it is from which year, ma'am?
study में fetal outcome था क्या?
Recent one.
This ACOG guideline is from 2016 consensus, which I took.
Right. The last study also, ma'am.
The last slide, ma'am. The last slide.
Last study काफी पुराना है. 2000 का है.
Okay. हाँ उसमें नहीं, क्योंकि उसमें शायद fetal outcome नहीं था. Fetal outcome तो जरूर गड़बड़ होगा. Maternal outcome में भी जो उन्होंने दिया वो दिया.
हाँ. नहीं अभी क्या है ना, that's what the problem with us is, no, we don't have good hospital records also. अभी ये लोग इतना बड़ा publication यूँ करते हैं क्योंकि उनके पास retrospective data बहुत strong रहता है. We don't have any SOPs for any data, anything, and we are so busy, हर रोज का दिन कैसे खत्म करें और आगे निकले ऐसे में चले जाते.
We have limited working hours, madam. We are working 24/7.
Yeah. नहीं 24/7 तू नहीं करेगी तो खाएगी क्या? That's the सवाल ना. It is a survival drive, my dear. It is not something that.
Reduce your numbers. Reduce your patient numbers. Now it is time to reduce patient numbers.
Oh, but sir, पैसा कहाँ से आएगा फिर reduce करने? Yeah. Hey, what happens is either the money will drive you or the patients will drive you, or I don't know what, maybe.
How many patients will drive you actually?
Yeah, patients drive you. नहीं madam, आपने ही करना है, आप ही करो ना, आप ही आना है, and all that. And then we also feel जाने दो अभी,
No, I have my actually I keep my patient fixed for 20 every day. Then 2 surgery elective, sometimes 3 or 4. So I have seen that my life is quite stable. Last 20.
Great.
Nice.
There's lots to learn from you. We women are not so sorted out.
I'm quite stable everything.
Thank you, ma'am. It was really
Thank you.
I enjoyed it
Very
a lot.
nice,
Thanks, ma'am.
panel.
Thank you so
Good
much.
night,
Thanks
everyone.
again. I hope we did justice to the topic. I don't know where Dr. Lakshmi is and where my dear.
Definitely.
No,
Supriya
actually,
is.
one thing, Dr. Giza, I want everybody to be concerned about the, cesarean section scar problems. It is not only the small cell, it is not only endometriosis, it is not only the arteriovenous malformation. So many things are coming out with the, uterine scar. It's really interesting. You just go for any AUB cases. It is not all cases that palm coin, that NAN part is very important now. So I have a series of almost 30 patients now. Out of these 30 patients, 2 patients I got cesarean scar endometriosis. That's quite interesting. Some records on that, and we can have a good.
One more thing I just want to say is वो जो हमारा पुराना ये था ना principle, take the incision as low as possible. वो cancel करो अभी.
Yes, that has gone now. Yes.
Yes, ma'am.
Don't do it as low as possible because you will go into one khichdi and then land up in big problems.
Yes, that's true. During the cesarean also and afterwards also.
Yeah. So just UV fold के नीचे 2 सेंटीमीटर वहां आपका incision लो. That's the best part.
That was the most important skill that we, learned today, that we should be doing it in every case. Yes.
Yeah.
Placenta acquita syndrome is another problem coming up like anything.
Yes.
Very, very.
Now, sir, I have one patient who has undergone a C-section for an IUD at term in Jammu. And she was not getting pregnant. She came, I just gave her some pre-pregnancy optimization, weight loss, and she conceived naturally. Abhi she become 7 weeks pregnant and there is a big vascular niche in the myometrium around it.
Be careful.
अच्छा बाबा मैं अभी क्या बोलूं ऐसे होगा I'm so much stressed because I'm talking to her every time I'm writing this is a possibility, that is a possibility. She very innocently looks at me. कि बस मेरे को बेबी दे दे, वो तेरा पॉसिबिलिटी खड्डे में जाने दे.
Yeah. The uterine wall, definitely it may be difficult towards the bladder, but you should go for a MRI at around 24 weeks to confirm it.
I'll just see now. I'm keeping a watch on her. Hopefully, things should fall in place.
Okay, so nice to
And if there is nobody to say us bye, Supriya, where are you? Supriya, Lakshmi.
We are in touch, it seems.
Thank you, ma'am.
Thank you, ma'am. Thank you. Bye bye. I think we'll say bye bye to one of us.
Bye, ma'am. Good night.
Bye.
It was a very nice discussion, very nice panel discussion.
Oh, my dear friend Jyotika is there. Love you, my dear.
It was lovely, Girija.
Thank
I
you
was
so much.
enjoying quietly.
Your appreciation is very important for me. Hi, Lakshmi madam, can we leave?
Bye.
Lakshmi Pratyaksh hui.
Look, Lakshmi madam has left.
It's okay, Girija. We say bye-bye to ourselves.
Bye, everyone.
Yeah, bye.
Okay, bye. Bye. Good night, ma'am.